Who is everybody? Where is everybody? Yeah, it is. It's a weird Wednesday. Sure. Yeah, come see Jake. Jake.
That is odd. Oh, I know what it is. Okay. Why is it?
Let me come over.
Video capture device, Black Magic Design, right?
Yeah. All right.
Restart.
Unplug.
Unplug what?
The stand by, guys. We're having some technical difficulties. Sorry. Oh. We're trying to get the cameras up. Just give us 1 second here. Try again. All right. I think we're live. Woo, Wednesdays. Almost as bad as Mondays. All right, you guys had chapter 7 over the break between classes. How did you guys do? Any questions on chapter 7? Easier? Okay. Good. Okay. Sandra says, thanks for your video yesterday. I passed both my exam CNA. Congratulations, Sandra. Great job. And Nikisha says, I'm excited to say I'm now a licensed CNA. Thank you for those amazing videos. Congratulations, Nikisha. Great job. Welcome to healthcare. All right. So let me go ahead and get your scores on chapter 7. over the weekend, you're going to have 8 and 9. The chapters are going to get a little easier from this point. Chapter 8 is on nutrition. It's barely skimming the surface of nutrition. I mean, it's really basics. But there are a few diets on there that you do need to be aware of. And the biggest thing is we have to understand that what a patient eats is going to affect their health conditions in a very big way. And because we're responsible for serving them food and snacks, we're going to be a part of that whole chain. So we've got to make sure we're giving the right tray to the right patients at the right time and noticing anything that might be off and reporting that. So we do need to know that there are different diets. They matter. Be aware of the diets. Make some flashcards for the diets. But they're just general, like low sodium. They're going to talk to you about how to thicken liquids because some people have swallowing problems with thin liquids. So we thicken them with a product called Thicket. And it's just like a powder that you put into the liquid. You stir it up. It's not supposed to change the taste. It just changes the texture. A lot of patients don't like it. I mean, imagine trying to swallow water that is like pudding. It's weird, and it's hard to get patients hydrated enough when we thicken their liquids. So when we're using thickeners, please make sure that you're watching your patients for signs of dehydration. Okay, make sense? Okay. All right, Daisy, how'd you do on 7? Daisy? No. Chile? Emily? Madison? Thank you. Michael? Sydney? Natalie? It's fine. Adrian? Dakota? Sure.
It says for the last question that for PPE, the first thing you put on is a gown. Is that only for like if there's going to be fluid?
Okay, so that, let me send you to the lesson so that you can see it. Hold on one second. Oh, where is it? Yeah, gloves is not right. Gloves is going to be the last thing that you put on. Okay, so let's talk about PEP. I'm trying to get you the page so you know where to find it in the book, but I'll go through it with you. So the way PPE works, remember our rule, the first thing your gloves should touch is the patient, which means that they need to be the last thing that goes on. Does that make sense? Okay. So we're going to wear the PPE we need for the job that we're doing. And good morning. Where is 124 in your book? 124 and 125. So there's a chart on page 125 that shows you how to put on and take off your PPE. So we're not going to wear a gown for everything. If we're doing hand and nail care, we don't need a gown over our clothes. Remember I said that your clothes, your uniform is not going to be considered clean once you start work. That's because, you lean up against stuff, you kneel on stuff, we've got pathogens that we've encountered. What we want to try to do is prevent what we call gross contamination. So if we're going to be working with things that splash, we don't want that splashing to get onto our clothing. Now, we're going to cover a skill on Monday where you have to wear a gown, and that's when you're cleaning a bedpan. If you're using a specific bedpan cleaner, which is attached to a toilet, we'll go over that on Monday, you're going to get splashing because you've got water under pressure hitting a flat plastic surface. You're going to get splashback. That's just, we expect that. We don't want that on our uniform. Make sense? Because you're wearing a uniform into the cafeteria and home and, other places. So in that situation, if we're going to be working with splashing items, then we need to cover our clothing with an extra layer. something we can take off when we're done with the skill. So that's the gown. That's going to be the first thing we put on, right? We're going to cover the biggest part first. Put the gown on first. So with bedpan, you would need a gown. But because it's splashing, you probably want to cover the holes on your face too. You don't want urine in your eyes, nose, or mouth. That's just gross. So you would want to put on a mask and some sort of eye protection, right? You also need a mask if we're going to be working with patients that have diseases that are transmitted through the air or through droplets if we're going to be in close contact. Make sense? Good. So we want to put the gown on first, cover the biggest area, and then we're going to put whatever we need on the face. Sometimes it's a mask with a face shield attached. Make sense? Sometimes it's just the mask, or, well, it's never just the goggles, unless you're working in a lab. And then the last thing that we do is the gloves, right? So if you look on page 125, it's going to tell you how to put these items on in the right order. So gown is going to come first, cover the biggest area. Then the mask. Then the eyewear, which is often attached to the mask. It's like a shield. And then the last thing is going to be your gloves, because the first thing the gloves should touch is the patient. Good? Make sense? Now, putting them on, there's an order there, but it's not as critical as taking them off. The way we take them off really matters because of cross-contamination. Now these items are dirty, and we've got to take them off in the right order. The first things that have to come off is the gloves, because you're going to touch everything else. Like if I want to take off that eyewear and I've got dirty gloves on, I'm putting dirty gloves up near all of my holes. This is not a good situation, right? So get those gloves off. Make sense? Right? Then we go top to bottom. We do eyewear first. Okay. Then we do our gown. Right, top to bottom, gown. The last thing to come off is the mask. Now, do you remember I said that we had to, if we're working with a disease that's transmitted through the air or through droplets, right? We have to have a mask. So that means that we're trying to filter the air that's in the area. Everybody good with that? Makes sense? You want that to be the last thing you remove, because otherwise you're breathing in that air while you're doing all these other things. So does everybody understand the order there and why it matters? Every couple of years, the testing company meets and they come up with new skills. They get rid of old skills. They, kind of move some things around, change the testing checkpoints based on the needs, of the healthcare system, because things evolve over time. This is one skill that I do believe will become a skill, a tested skill shortly, is putting on PPE in the right order and taking off PPE in the right order. It's something you do need to know. And it's something that could show up on the written test, not the skills at this time, but it could show up on the written test. So take a little bit of time to learn this. But in a clinical setting, if you're working with a patient that requires these types of extra steps, they're called transmission-based precautions. If you look at the second column, page 124, you're going to see a little graph or a little placard there. This is something that would be on the door of that room. And it's going to tell you what needs to be worn. And in a lot of facilities, they actually have donning and doffing order on that card that's on the door, so that we're not relying on your memory when you've got call lights going off and 15 patients and doctors yelling at you and all this other stuff. it's right there written out for you. So a lot of facilities will make this easy because they don't want you to contaminate yourself and then take that contamination into other patients. It just makes sense. Does that help you? Yeah. Whenever we're talking about things like this, I always like to show you in the book where it is, because you're not going to remember this. In 2 weeks, you're going to go, oh, what was the order of that? I don't remember. I need you to know you can find it in the book. That way you're not emailing me in 2 weeks going, what was the order we took that stuff off in? You know to go to your book to find that information. Okay, good. All right, good question. Very good question. All right. So this is our final review. I told you class 6 was our last review, right? We won't have a review for class 7, and we're definitely not going to have one for class 8. So this is it. If you decide that you want a full review before you go test, remember your first hour of class 6 is where you want to go watch the replay. It won't take a full hour. But we have covered a lot of stuff. I want you to think back to the first day that you were here, right? We only have 2 classes left. That's it. We're 3/4 of the way done. Has it been hard? No. I know homework's a little challenging, right? To work that in. Nobody likes homework. I get it. One of the things that I'm working on right now, and I'm really working hard on this, is how many of you guys have gone into the online course? Anybody gone into the online course yet? Okay. So one of the things that I am working on is creating lessons in that online course for the topics that you're reading in your textbook. And eventually, once I get it all done, students won't have a textbook to read. They'll be able to do short lessons in the online course for each one of these topics. And they're a little more engaging and a little more fun than just sitting down and trying to read. So that's something that I'm actively working on. I got 3 lessons done yesterday. So it does take me some time to do these lessons. Probably by the end of the year, we'll be able to get rid of that textbook homework, which would be amazing, right? Especially because the questions are built into each lesson. So it's you don't have to go take a test. And I think it's going to be better for you guys as far as retention goes. You will have access to that online course for a year. So even after your test is over, if you get into a situation where you are like, up until this point, I really haven't done a whole lot with turning patients, and I don't really remember that process, you can go back into the online course and see it. So you're still able to access all of this content. So as I add these new lessons, you guys will be able to take a look at those as well. All right, so here's our review. We have covered a lot of information over this the last 3 weeks, but it all starts here. This was the very first lesson that we did, and this is the most important lesson that we learn, because if we don't understand where to go to get the information we need to do these skills, if we're making stuff up on our own, we're actually operating as a nurse outside of our scope of practice, and that's not a good thing for anyone. So we are going to follow the care plan. That's what's going to tell us what to do. And we follow the care plan, the whole care plan, and nothing but the care plan. So that means that we don't change it, add to it, take away from it. It is exactly as it stands. While we're following that care plan, we should be making observations. Who are we going to report those observations to? The nurse. So let me stop there for a second, because this is so important. I just saw another post on Facebook about this. You and the nurse have to work as a team to defeat whatever's trying to kill your patient. You are a team. If one of you is not working with the other one, you are no longer a team. So that means whatever's trying to kill the patient has a much better chance of succeeding, because you are not a team. Make sense? It's like a football game. If you throw the ball to somebody and he runs to the other end of the field and scores a touchdown for the other team, that didn't help you. You were not a team. Okay. So we have to work together. If you find yourself in a situation where it's you versus the nurse, the patient is the one that's going to pay. Now, I see a lot of posts online. A lot of CNAs out there get this wrong. They're confused. They think that they know best for the patient. And the CNA is not the one with the liability. If the nurse asks you to do something, that nurse is the one that's liable for what they ask you to do. They think it's in the best interest of the patient. And if you decide on your own not to do that thing, whatever that thing is, it's the patient that's going to suffer. So don't get into a power struggle with your nurses. And I'm going to tell you flat out, in that situation, you are the one that's going to lose every time. That facility will fire you in a heartbeat. They will not fire the nurse because it takes a whole lot longer to grow a new nurse than it does to grow a new CNA. Does that make sense? So if there's a power dynamic between you and the nurse, you will lose. It's that simple. Now, if you're working with a nurse and that nurse is doing something that you think is actively, or asking you to do something that you think is actively against the patient's best interests, then you need to go up your chain of command. You need to go to the supervisor and say, hey, listen, I know I'm a CNA, but the nurse is asking me to do this thing, and I just don't think that's a good idea. You know, if we have a patient that's been in bed for 7 days, no range of motion exercises, they've just been laying there for 7 days, and the nurse says, hey, I need you to get them up and to the bathroom. Is that patient strong? No. So is that a good idea? No, maybe dangle them, maybe take them on a short 2 or 3 step walk first, maybe get physical therapy involved. A walker might be a good idea. We got to take some steps here because 7 days in bed, that patient probably isn't strong enough to make it all the way to the bathroom. Okay. So if something is happening that you think is actively against the patient's best interest and you're pretty sure, hey, that patient is probably going to fall, this is not safe, then you need to first bring it up to the nurse. Are you sure? Because that just doesn't seem safe to me. And then take it up your chain of command. So go to the supervisor and say, hey, I'm a CNA and I'll do what you guys want me to do, but I just don't think it's safe for this patient. Can you assess? Can you weigh in? Because sometimes a second set of eyes is a good thing. Good? Make sense? Maybe that nurse isn't aware that they've been laying in bed for 7 days without moving. Maybe. But be careful there. Don't change the care plan on your own. Okay. When we're working as a team, that means that team has to have all the information you have. Everything. If you know it, the team should know it. Don't keep anything to yourself. The term now is gatekeeping. Yeah, there's no gatekeeping in CNA world. Good? Does that make sense? Okay. Every skill starts with the opening. Every opening starts with a knock, and it is a graded checkpoint. Now, some of you guys were in here practicing on Monday, and I kind of hung back and I watched what happened, and most of you guys did a great job. I'm super proud. You've learned a lot. But some of you practiced some of these skills without doing the opening. You didn't practice the skill. You practiced a few steps of the skill. And the way you practice is the way you will perform on the test. And if you're not doing the opening when you're practicing, you're not doing the skill. And you risk during the test forgetting to do the opening. So make sure you're practicing with intention. Do the opening. Start with the knock. And we timed it on one class. Remember, it was less than 20 seconds. In your practice time, I'm sure you've got 20 seconds to spare for the opening. Work it in, because otherwise you will forget during the test. So every skill starts with the opening. It's non-negotiable. And every opening starts with a knock. Okay. Once we've entered the room, we're going to greet the resident by name. By name, not the ID band. Can you touch the patient yet? Okay, by name. Now, what if we have a dementia patient that can't tell us their name, or they can't speak because of a stroke or an accident, or from cancer? Excuse me, they had their voice box removed. What if they can't tell us their name? What do? Well, we follow the care plan, which, remember, that care plan is done by a nurse who did a head-to-toe assessment, and this is one of the things the nurse has to look at. How do we make sure we have the right patient? So we're going to follow the care plan for that particular patient. Okay, good. So we're going to greet the resident by name. Once we've done that, we're going to introduce ourselves by name and title. Hi, I'm Patty, your CNA today. Then we're going to tell them what we're there to do. I don't care how you put it. They don't care how you put it. You can read it right off the care plan if you want to, or you can put it in your own words. I'm here to do hand and nail care. I'm here to give you a mini manicure today. You know, however you want to put it, just keep it professional. And then we're going to get consent. Consent is important. It's part of patient rights. Patients have the right to control their own health care. We're doing things on another person's body. Think of all the things you do to another person's body. You need consent for all of it. This is no different. Make sense? Okay. Once we've done that, we can close the curtain. Is the curtain clean? No. So what do we want to do after we close the curtain? Wash our hands. That's right. And then you can go get your supplies. So when we're thinking about supplies, we have to think about gloves. We don't use gloves for every skill, but we will use them if we could possibly touch body fluids, personal skin, or non-intact skin. So if there's a maybe in there, if I have to change this lady's sheets and I'm not sure if she's wearing undergarments and I'm not sure if anything leaked out of her, should I wear gloves? Absolutely, because there's a maybe there. Now, if I go in to change this patient's sheets and they are fully clothed and holding on to all of their own body fluids, do I need gloves for that skill? So we're going to base it on the patient that we're doing that skill on, that particular skill, not global. Good? So if there's a possibility we might touch body fluids, personal skin, or non-intact skin, we'll wear some gloves. But if we're going to wear gloves, what's the first thing they should touch? The patient. Do all your prep work first. You don't want gloves that have touched a whole bunch of stuff in your mouth if I'm going to brush your teeth. You want clean gloves. So does your patient. So the first thing your gloves should touch is the patient. Now, once you've touched that patient, be aware of what you're touching in the environment. Don't touch that sheet that's going to go right up next to their face with dirty gloves. That's just gross. Don't hand them a call light with dirty gloves. That's just gross. Don't open the curtain with dirty gloves and leave those pathogens for other people. That's just gross. Pay attention to what you're touching. And then we're going to remove those gloves properly at the end of the skill by pinching up, pulling off, going under, and pulling off. Good. Now, if we're going to use supplies, we need a place to put them, and that's where our barrier is going to come in. Our barrier gives us a clean place to put our clean supplies, and you can only touch supplies with clean hands. Don't let your supplies touch your uniform, and you're going to get that barrier before you go get the rest of your supplies. That way you're not tempted to hold those supplies up against you while you try to spread out that barrier. One of the supplies that you might need for a skill is a privacy blanket. Now, we're going to use a privacy blanket anytime our patient is uncovered or undressed. What should I never see? Knobby knees. If you look over, if you look over and you can see the patient's knobby knees, you should hear my voice in your head going, stop. That patient should be covered. Good? Make sense? Okay. All right. So remember, that blanket is not just there for privacy, though. It's also there to keep the patient warm. They have a different temperature perception than you do. Just like in this room, you guys all think it's colder than I do. Different temperature perception. Are you? Don't stand up here because I don't get very much air up here. Yeah, I would be better going over there. I'd actually get some air. If we're going to use a privacy blanket, we put it on, we're putting it on over the sheet, not snapping it or shaking it, just laying it out over the sheet. And then we'll pull that sheet down underneath the blanket. That way the patient's always covered. Don't just rip the sheet off and then put the blanket on. No knobby knees. And then at the end of the skill, you have to wait until after you remove your gloves to remove the blanket. Another supply that we might need are some sort of linens. Now, linens can be sheets, they can be the privacy blanket, they might be towels or washcloths, they could be a patient gown or patient clothing. That all falls under linens. And all of these are principles. The first couple are principles we've already learned. Things like you have to have clean hands to get clean linens. And those linens cannot touch your uniform, and we don't snap or shake anything. We also have to remember that nothing touches the floor, ever. We don't put dirty items on the floor. We also don't let clean items go on the floor. Clean rolls toward me, dirty rolls away. We use that anytime we put something under the patient. So whether it's a sheet, a chucks, a towel, anything, clean rolls toward me, dirty rolls away. And then anything you take off of the supply shelf that you don't use has to be discarded. Don't save it for later. Don't put it back. Discard it. So you got to learn your supplies. Take what you need, but use what you take. Now, that all deals with the beginning of the skill and the supplies that we need. Everything else that we're going to learn deals with the patient and some sort of safety with the patient. So the first one that we're going to talk about that's dealing with the patient is scoot and roll. Your patient must be in the middle of the bed at all times, and we can't rely on side rails to keep them there. You're not going to have side rails in every setting, so we can't rely on side rails for safety. That's our job. And as long as your patient's in the middle of the bed, we don't need side rails for this. So if we're going to turn a patient and we know they have to be in the middle of the bed, we're going to scoot them toward us and then roll them away from us. And we will remain behind the patient's behind, always away from us. Good. Patient always has to be in the middle of the bed, always. Now, I'm going to tell you that this principle actually came from one specific student that I had. I developed this whole principle for one student about 10 years ago. That student sat in the classroom, did the work, went and took the test, and failed the test because of one checkpoint. And the student was very upset when they came back to me. And they showed me their printout, they showed me their deficiency, and I asked the student, what happened? Tell me, walk me through it. Tell me during the test what you did and what happened. And she said, the student said, I turned the patient like the care plan told me to. I put him on the correct side. I did the whole arm up, arm over, leg bent, like I did all of that, turned them on their side. I put all the pillows in place. I did all of that. And I still failed. And I said, well, according to the checkpoint, why did you fail? The patient wasn't in the middle of the bed. I said, did you stop and look at the patient after you did the skill? She says, well, I saw that they were kind of close to the edge, but I did the skill. Is it enough to just do the skill? At the end of the day, if we just do the skill and don't really pay attention to the patient we're doing the skill on, did we really help? Help isn't help if it doesn't help. If we leave that patient for 2 hours hanging on the edge of the bed, are they comfortable? Yeah, there's a likelihood of them falling, but even worse than that is for the next 2 hours, even if they don't fall, they're now afraid they will. That's psychological torture, guys. You imagine being on the edge of the bed, not being able to save yourselves for 2 whole hours and being afraid to even breathe. That's why that checkpoint exists. So I realized that maybe I wasn't getting that through to the students. So I created an entire principle based on that one student. Everything that we have learned, these are all things that I created. These principles are not taught anywhere but here. Now, to you, they're foundational. How in the world would you do any of this stuff without these principles? How would you? Because I've made it part of the skill. But that's not how a lot of your coworkers are going to do their jobs. And you need to understand that, because part of what you do may be protecting your patients against your coworkers as well. If you notice a coworker doing something that could put our patients at risk, what should you do with that information? Tell the nurse. That's right. Don't confront the CNA. You are not a supervisor. They will see it as you going above your station. What you need to do is notify the RN, hey, not trying to snitch, but I did notice that the patient's very close to the edge of the bed, and I'm very concerned. And I've noticed that this has been happening. Let the RN assess whether we need more more education for that CNA. Make sense? Okay, don't confront. Not your job. So that's where this particular principle, I actually wrote this on a cruise ship, by the way. I created this. I created the whole presentation in the online course on a cruise ship. It's where I do my best thinking, because I don't have to cook. I don't have to clean. I don't have to do anything but sit on a balcony with my laptop and just type away. I am the happy clam on a cruise ship. That's why I've taken so many of them. That's where most of this book got written. Yeah. So yeah, for me, all of my vacations are working vacations. My children will tell you I do not take time off. I work 7 days a week, generally 12 to 14-hour days. I do not take time off. I can't. My brain won't let me. It just won't let me. I'm constantly going. I'm pretty sure that I have ADHD. They just, growing up, that was just who I was. But I cannot turn it off. But when you come to me with these issues after graduation, don't be surprised if I don't use them in training, because issues that you have, other people may have as well. And they're great learning opportunities. So this is another patient-centered step, right? Washing rules. This is all safety. Every bit of this is safety, and safety counts big on the state exam. So we don't put soap in our water. Basins are no soap zones because we have to be able to rinse. If you don't rinse, the soap dries on the skin and the patient gets itchy and they scratch, and now we've got another body opening. Safety. So that step, safety. Crazy. The written test is going to grade you pretty big on safety. If you don't know these principles, that written test is going to be very, very hard for you. Now that you know the principles, you're going to go through the written test, go, oh my gosh, this is so easy. This is crazy easy. And I'll talk to you about that at the end of class today. Remind me at the end of class today. We use a paper towel to turn the faucet on because the faucet is dirty. Infection control. We use warm water only, not hot, not cold. That's because of the temperature difference in perception. Safety. We're going to allow the patient to check the water temperature. Safety. We're going to use the leaves method for wet body openings. Safety. You starting to get this? We're not, whatever we wash, we rinse, whatever we rinse, we dry, and we don't get our surface wet. Again, safety, slipping hazards. We want to warm the lotion up before we use it and wipe it off after we put it on so that things don't slip. Safety, 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 safety. Safety counts big on the state exam. Basin cleaning is also about the patient, because when we put that basin away, no matter what it is, we put that basin in this drawer, that drawer blocks out light and there's no air circulation, so it's automatically warm. When you put a wet basin in the drawer, we now have moist. What grows in warm, dark, moist? Pathogens. Yeah, bacteria, viruses, yeast, fungi, all the bad stuff, all the bad stuff. So we want to try to prevent that from being an environment that we're going to use things out of. So wash, rinse, dry your basin. For the test, you don't have to use soap. You don't have to disinfect. We're just going to rinse, dry, and store. But I want you to be aware of how to put that disinfection step in if you need to. Now, if I ran a facility, it's one of my bucket list items. If I ran a facility, every basin would be disinfected before it was stored. Every basin. I think that's a really good idea. I think it's low-hanging fruit. It's a really easy way to try to prevent cross-contamination. But for the test, we're not going to do that. We're simply going to rinse, dry, and store, and this process shows us how. So we dump the basin, we rinse it, we dump the rinse water wherever the item went, the liquid went, and then we set it down. Disinfect it if you need to. We're going to use a paper towel to pick it up, so we're not picking that basin up with our dirty hand or dirty glove. Use paper towel to pick it up. Use paper towel to dry the inside, throw that away. We didn't disinfect the outside, so we need a different paper towel to dry the outside and throw that away. And then we need one to open the drawer with, because that drawer shouldn't be grossly contaminated with your dirty hands or gloves. Good. And then we learned shoe rules. Now, this was the last one that we learned, so it's the closest in our memory banks. Slipper socks are not enough. Remember, slipper socks do not protect against sharp objects or blunt force trauma. If we're going to walk a patient, or if their feet are going to hit the floor for any reason, we really need some shoes on those patients. And this is a testing principle. You want to make sure that anytime the patient's feet hit the floor, we're at least talking about their shoes. We're mentioning them. We're saying, I see you have shoes on. Do your shoes fit well? Something along those lines. Yes.
It's crazy because I've been seeing like on TikTok, people do the still and they only put the socks on.
Yep.
Like, most of these people, they do it very differently than what you teach us. And I noticed, like, you know, they're doing it kind of.
Yes.
What about in hospital settings? Like I've noticed a lot of hospital settings, patients don't wear shoes.
Mm-hmm.
Is it just because it's like a hospital is less likely to step on something, I guess?
So let's look at that. I'm going to pull up a chair because we're going to have a conversation. You opened up a door you're probably going to wish you didn't open. All right, so let's talk about that. Explain to me what kind of patients we have at a hospital. Somebody.
All kinds, young, old,
Okay.
long-term, short-term illnesses.
Okay, chronic illnesses.
Oh, yeah. People that have like acute.
Okay, acute. So these are short-termers, right? Right? Short-termers. Where do they go if they need long-term care? Yeah, long-term care facility. We actually call it that, long-term care facility, like a nursing home. Okay, so hospitals, short-term care. How do you get into a hospital? Can you call and make a reservation? How do you get into a hospital? Okay, you have to qualify. You have to be very sick. You have to go in through the ER, and a doctor has to say you're sick enough to have a bed here. Or your main doctor is going to admit you to the hospital and say this person is sick enough to be there. So in a community, where are the sickest people? If I wanted to find the sickest people in this county, where would I go? The hospital. So we have an environment with the worst pathogens in the community. The worst. In fact, these are bad enough to make somebody sick enough to not be where they normally live. These are the worst. Now, because these patients are so sick, we use all kinds of medications that we wouldn't normally use in long-term care, things like IVs. Now, how do we get an IV in a patient? We use, what is it? A needle. We also give injections. What do we give injections with? A needle. We do procedures like surgeries or bedside, what we do, cut downs or insert chest tubes. And those all require scalpels and sutures. And so are we talking about dull objects here? So we have the sickest people in the community, so their immune systems are already busy. We have the worst pathogens in the community because they're all there. And we have sharp objects being used routinely. Now, does this sound like a safe place to be walking around in socks? No. Now, let me give you one more scenario. Now, this one's really gross, but it helps illustrate my point. Let's say that I had my gallbladder out this morning and I went to a same-day surgery center, went in early in the morning. They did it, through the robots. They took my gallbladder out. I was supposed to go home that evening, right? They don't keep you overnight anymore. They just, zip, 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 do what they need to do, and they send you home. I was supposed to go home. But my blood pressure is super high. Mine does that every once in a while. And they can't send me home with blood pressure that's high after surgery. So they have to send me to the hospital. So here I am, just had surgery. I got a couple small incisions on my tummy that are only covered with a Band-Aid, not even like a real dressing. And it's got gaps, right? Now, remember, incisions are warm, dark, moist, right? So they give me a bed in the hospital, and this is my roommate. I don't get to pick my roommate, right? There's a female in the bed. There's an empty bed. I get that one. So this lady, she is in her 80s. She had a hip fracture, and she had a hip replacement 3 days ago. Now, she ended up with an infection in her surgical site, and they started her on an IV antibiotic that's really, really strong. And unfortunately, one of the side effects of strong antibiotics is often diarrhea. So she can't get out of bed. She's got a broken hip and she's got an infection. So she ends up with diarrhea in the bed. It's a mess. CNAs come in, they change the sheets, they clean her up, but there's no hamper in the room. So where do you think that CNA throws the sheets? On the floor. So they clean her up. They threw the sheets on the floor. Now, I'm in the bed next to them. The curtain is drawn. I don't know what's happening, but eventually I have to get up and go to the bathroom. Remember, I'm able-bodied. I was supposed to go home. The only reason I'm here is for blood pressure. I can walk. So I get out of bed with my little slipper socks on, because that's, standard issue. And I walk to the bathroom. And I do what I need to do in the bathroom. And then I walk back to bed, and I get back into bed with those socks on. Now, what just got into bed with me? All of the pathogens, not just the diarrhea from the sheets from this lady. Remember, that's a surgical site infection, right? So there's definite pathogens, no doubt pathogens. But I also walked through whatever was in the bathroom and then got back into bed with those slipper socks on. Now remember, I've got warm, dark, moist openings that are only covered by a Band-Aid. As I toss and turn and move in that bed, those pathogens are going to get closer and closer. And who else is going to get a surgical site infection? Why did I get one? Because I walked in a clinical setting without shoes. So the answer to your question is, I know it's a very long answer, but the answer to your question is the hospital is the one place out of all of them that you should have shoes on. because all of the risk factors are there. You've got a patient population with depressed immune function. You have a predominant amount of pathogens that are all different and severe. You have sharp objects that are routinely used in that environment. And you've got lots of artificial body openings that are still wet. So there is no reason that you should not have shoes on. Now, I'm going to tell you, I've seen it. In fact, if you go, and here's a fun activity you can do for lunch. If you go over here to this hospital, right up, don't say the name, but the hospital right up the road, okay, right up that way, they have a Subway in the lobby. Go there for lunch. Grab a sandwich, take a seat, and watch how many patients in hospital gowns and slipper socks are walking to the Subway or walking outside to have a cigarette. In socks. Now they're going to carry all of those pathogens right back, not just to bed, but every surface they walk on to get to that bed. Is this a good idea? Now, full disclosure, I worked in a hospital for years, and I had no idea about this. All of my patients walked around in slipper socks too. I didn't put shoes on them. I never once thought about this. Never once. Because we're so ingrained, right? That's standard issue. You go to a hospital, you get a gown and socks. I mean, that's what you're going to wear. That is your uniform. We don't think about it. And you didn't think about it either until about 7 minutes ago. Now, this lesson is in your brain and you won't be able to see it any other way. But the nurse that you're working with may not have ever heard this or may not have ever thought about this. So a very easy way of saying this is, yeah, do you know how many pathogens might be on that floor? You know, from dirty towels or dirty items on the floor, or patients that can't make it to the bathroom. That happens. That happens a lot. So my guiding principle here, and it has always, this is, once this became apparent to me, this has been my guiding principle. If I would not let a 2-year-old walk on that floor in bare feet, I should not let an adult walk on that floor in socks. Why are 2-year-olds better protected than our vulnerable adults? Not in a hospital, they don't. Their immune system's busy. It's a different way of looking at it, isn't it? Who, 2-year-olds?
Oh, never mind. I was thinking of like a baby.
Yeah, if I wouldn't let a 2-year-old walk barefoot on that floor, I should not let an adult walk on it in socks.
I was gonna say, what if the care plan says, like just to put on socks?
If the care plan says so, that's fine. But here's the thought process for me. And you're going to have patients that are so swollen that they can't get shoes on. You know, especially our CHF patients. Their legs and their feet get so swollen that not even slippers are going to fit on them. So we're stuck with slipper socks. I get it. I understand. However, I'm going to take 2 precautions in that situation. The first is I'm looking for any sharp objects that might be in their walkway. I'm going to take extra special care. Second thing I'm going to do is put an extra set of socks on. One that is going to cover their socks while they're walking and that I can take off before they get into bed. Okay. So my care plans would say second set of socks while out of bed. And that's why. So the nurse's job is to identify potential problems. Remember that word I used on the very first day? Real problems and potential problems. This is a potential problem. So my job is to identify it as a potential problem and come up with a plan to prevent that from happening. Good? told you you're going to regret asking me that question.
I took the practice test again, and this is actually a test question. It says that a patient cannot be discharged from the hospital unless they have shoes.
That is correct.
And I thought, that's ridiculous. How is the healthcare system's responsibility to provide shoes for that patient? But that's the correct answer.
That is correct. Yep.
Thanks.
Yeah. We can't dump somebody off. And the problem is, if this wasn't a rule, hospitals would do this. They would just throw you on a bus and drop you off on a corner. They don't care what happens to you after that. They don't care. They're a corporation. Their obligation is to their shareholders, not to the patients. You are a product. You are a product. Their obligation is to get better dividends for their shareholders. So they have no problems throwing a patient after they've wrung every cent out of them that they can, throwing them on a bus and dropping them off 3 blocks away on a street corner and, hey, you're on your own now. But we can't do that if they don't have shoes. So what does that tell us about the importance of shoes for overall health? Right? If it's important out of the hospital, it should also be important in the hospital. Now, a next question that somebody's going to ask in here, but Miss Patty, what if they don't have shoes? Yeah. What if they don't have shoes? Well, that's an easy one. Tell the nurse. Use a second set of slipper socks. I'm in favor of that, to protect them while they're walking. That's fine. Take them off before they get back in bed. That helps with the infection control thing. But tell the nurse, because the nurse can find shoes for them. We can call the family or the facility they came from or the social worker. Remember, we can't discharge them without shoes anyway. Not if they walk. If they walk, they have to have shoes. So just let the nurse know, and the nurse gets to solve that problem. Yay. Yay. Nurses, this is totally off topic, but I always found this interesting. Nursing is the only degree that you can get, the only degree that requires 3 years of education, but they only give you a 2-year degree. That is nursing. It requires 3 years because you have to have prereqs before you can get into the RN program. It's a year of prereqs, usually a little longer than a year, actually. It used to be you had to have your maths, your Englishes, at least 2 social sciences, and then nutrition, microbiology, anatomy and physiology, 1 and 2, body systems and processes. So, I mean, you're talking about a year to 2 years of education before you even get into the RN program. But the reason for that, we can all complain about it, but there's a reason for it. Because RNs have to look for real and potential problems. And some of the problems that you're going to bring to me are social problems. They're not science-based problems. They're not nursing problems. Getting this guy a pair of shoes is not a nursing problem. That's a social problem. But it's still one I have to solve. So I have to have the knowledge, which is humanities and social sciences. So that's why all of these prerequisites exist, because as a nurse, you're going to have to function on multiple levels. It would be like asking an engineer to bake a cake. It's not really part of what they normally do. But with nursing, it is. So we have to be very well-rounded. Does that make sense? Good. I always found that very interesting. Why do I only get a 2-year degree when I've been here 3.5 years?
If you get in, I got all the prereqs and I qualified to go in, but I didn't. I had 52 points, and there were other students that had points in the 60s and stuff, so they got the chairs.
That's right.
And
it is competitive entry.
it's very competitive. So I was like, dang. No, I have to wait a year.
Yeah, it is competitive entry. That's right. Now, your other option is to go to a for-profit school where you can get in, but you're going to pay 3 times as much for that education.
If I was 20, I'll do it because I don't have time to pay student loans and stuff.
Yeah,
I'm 46. I am not gonna get into a student loan at this age.
yeah. All right. So when we're talking about shoe rules, if the patient's feet hit the floor, we got to talk about the shoes. Slipper socks are not enough. If we're going to use a gait belt, we put it on and we want to make sure it's snug enough to stay on. It goes over their clothing, around their waist, and we're going to check it with 4 fingers to make sure it's going to stay in place. We use proper body mechanics when we lift. So 1 foot in front of the feet, 1 foot beside the feet. Grab the back of the gait belt or around the sides. Have them put their hands on your shoulders as you lift. Let them stand there for a second. Let them get their bearings. Ask them if they're dizzy. And then you're going to walk however far the care plan tells you. You're going to return to the bed. But while you're walking, they should be your full attention. Hand in an underhand grip on that gait belt, underhand. That way you're able to kind of feel and redirect. If you have an overhand grip and they start to fall, that gait belt can slip right out of your hand. If you have an underhand grip and they start to fall, your hand is going to catch that gait belt. Okay, good. When we get them back to the chair along the way, we want to make sure that they're not dizzy or weak. We're watching them. We're asking them. When we get back to the chair, we want their legs to hit the back of the chair. That way they know it's there before we help them sit. We'll remove that gait belt at the end. Don't pull it across the skin though. Okay, good. All right, and then we end all skills the same way with the closing. And the closing sounds like this. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Your environment is clean. Bed is in the low position. Here's your call light. Let me know if you need anything. Open the curtain and go wash my hands. Now, washing my hands is the last thing I do because if I come back and touch any of those items, I've re-cootied up. So I want to get all of that done before I go wash my hands. Doesn't matter what order you do all of those things. Give them the call light first. That's fine. Open the curtain first. That's fine. Ask them if they're comfortable first. That's fine. I don't care how you do it. Just do it all before you go clean your hands. Then, if you have to document, that's going to come after you wash your hands because you don't want to touch this pen that's going to go home with you at the end of the day and in your pocket and all around with dirty hands. So wash your hands, then document. But our checkpoint says end skill with clean hands. So if we've documented, we haven't ended the skill yet. What do we need to do? Wash our hands again. Always the last step. If you have to return to the patient for any reason, go back and wash. It starts all over. Go back and wash your hands. Okay, good. Any questions on the principles that we have learned? On the back of your t-shirt that you guys are wearing, in the For Your, if you read those little tiny words on the back of the t-shirt, everything I just said is on your shirt. Everything I just said is on. Initially, when I created, you guys are like the third class that got these shirts. Initially, when I created these shirts, we were going to put them on the front. But I was afraid that students might try to wear them to the test. And if they're on the front, they'll keep you from wearing them because it's a cheat shirt. If they're on the back, you can't read it. I wouldn't, just because I don't want, again, it's a cheat shirt, right? I wouldn't, but remember that you have all the answers right on your back. Now, the CNA also has words. Those are tips for the written test. So For Your is the skills, CNA is for the written. So everything you need to know to pass the test, you have been wearing this entire class. But we had to learn them for them to make sense. All right, so now that we know those principles, let's review the skills that we've learned so far. Pulse. I'm going to go through this very quickly. Pulse. Pulse is a measurement of how many times the heart beat over 1 minute. Doesn't mean we have to count for a whole minute. It just means it's measured over 1 minute. So we're going to count as long as the care plan tells us to. Normal is between 60 and 100. The radial pulse is located at the top of the wrist, near the thumb, at the bendy part. We use 2 fingers, fingertips, not flat part. 2 fingers, not your thumb. Put your thumb on the back, find the pulse, pick a starting point on the clock, and we're going to count what we feel under our fingers until that second hand goes all the way around. This is a documentation skill, so you have to document. And for the test, you can be off by 4 beats in either direction. If you have 2 evaluators, Florida's supposed to have 2. There's a shortage of evaluators. I don't know how many you're going to have. If you have 2 evaluators, they may ask you to count with the second one. Just do what they ask you to do. Okay?
If you like count 15 seconds and multiply it by 4, do you get the same result or not as counting for 1 full minute?
You should. You should. It should be pretty close. Don't do that for the test, though, because our care plan specifically tells us to count for 1 full minute. Okay, so for the test, we're going to do what the care plan says, which is count for 1 full minute. But yeah, if you, let's say that I count, right? I find my pulse and I count 15. If we multiply 15 by 4, it gives us 60. Now, if I counted for 1 full minute, I probably would get 60, maybe 61, but it's going to be really close, within 4 beats. Okay. Our care plan for the test tells us 1 full minute. And we always follow the care plan. We learned how to dress a resident. You guys remember this? This is back in class 2. That was a long time ago. Okay, so dressing a resident with a weak arm, we're going to use USA first. USA first means undress strong arm first. That means that the old clothing just slides right off that weak arm. And then we'll undress that weak arm first, so the new clothing just slides right on. No motion required. We're going to ask our patient to pick their clothing. We're going to make sure that we get the clothing before we undress the patient to minimize exposure. You're going to lift from below with a flat palm, supporting all joints. Don't overextend or force movement. Make sure the patient looks good at the end, so adjust the clothing for neatness and appearance. Anything dirty goes in the hamper. Does it ever go on the floor? No, you can put it on the barrier until you're ready to go to the hamper. That's fine, but don't put it on the floor. And then the call light goes in the stronger hand. Hand and nail care. This is a mini Manny. Super easy. You're going to support the wrist and arm at all times. We'll soak the hand in water. You don't have to soak for any specific time for the test. You don't have to soak for 10 minutes or 2 minutes or anything. Just put the hand in the water. But in a clinical setting, I would let it soak for a little bit. It loosens up any debris, makes it easier to clean. Then we're going to clean, we're going to take the hand out of the basin after soaking, wash it, put it back into rinse, take it out to dry. Anytime it's out of the basin, it should be laying on a towel, not a hard surface. We'll clean under the nails with an orange stick, the slanted end of an orange stick. Go under each nail, wipe it off on the towel. Next nail, wipe it off on the towel. Next nail, wipe it off on the towel. And then we will file the rough edges toward the center. That may, not back and forth rapidly. After we've done that, when all nails are smooth and clean, we can put some lotion on. We'll warm it up first, wipe off the excess, and then clean your environment. That's it. That is hand and nail care. That's a pretty easy skill overall. Foot care is actually easier because we don't do anything with nails. You soak the foot, wash the foot, dry the foot, rinse the foot, or soak the foot, wash the foot, rinse the foot, dry the foot, and lotion the foot. Nothing with toenails. But you have to get on the floor, so that one is harder for me. Making an occupied bed. We change the bottom sheet a half at a time. So we'll, on one side of the bed, take the dirty sheet, roll it toward the patient, tuck it under, put the clean sheet on the bed, roll it toward us, tuck it under the dirty. Go around to the other side of the sheet, other side of the bed. I'm going too fast. Take the sheet off, unroll the clean sheet, smooth it out, minimize wrinkles. Put the top sheet on, take the privacy blanket away, make hospital corners, loosen the sheet over the toes, and replace the pillowcase. Opening of the pillowcase should face away from the door. That's making an occupied bed. Easy. This is a Houdini trick. I love this skill. We also have side lying position. Remember I said this is why we have scoot and roll. After you have turned a patient, where should they be? And if you don't look and make sure they're in the middle of the bed, I guarantee you the evaluator looked. So if you get all done with this skill and the patient's close to the edge of the bed, what should you do?
Make a correction.
Okay, you can make a correction.
Put the patient.
Yeah, you need to start over. Scoot them towards you. Get them in the middle of the bed. Don't ignore that, because when you ignore it, what does that tell the evaluator? What are you going to do in real life? Yeah, you're going to ignore it. And your patient is going to suffer the consequences of that. So if you get all done with this and the patient is not in the middle of the bed, you probably should move them. Okay. So in order to make this work, we have to remember you can't use side rails to enforce safety. So we're going to scoot our patient towards you. We're going to put an arm up, arm over, leg bent, leg angled, and we're going to roll them away from us. We'll put a pillow behind their back, go around to the other side of the bed, put one in between their legs, specifically between the knees and the ankles, with the top leg just a little bit off of the bottom, so they're not just, it's a lot of weight. Top leg just a little bit in front. A pillow under that top arm, and adjust the one under their head. Call light goes in the bottom hand. Bottom hand. Good. Foot care we just talked about. Mouth care, you're brushing teeth, guys. Just make sure they're in an upright sitting position. Protect their clothing with a towel. Wet the toothbrush, put some toothpaste on it, and brush. Let them rinse and spit as much as they need to. Make sure you dry their mouth after. Don't leave them a drippy, wet mess. That is the number one mistake made on this skill. Number one mistake. So don't leave them a drippy, wet mess. And then clean up. We don't have to floss. We're not doing anything crazy like that. We're just brushing teeth. Don't overthink it. For the test, you will throw that toothbrush away. It's disposable. Throw it away. Please don't rinse it out and put it in here, because that patient is not going to be in that bed in 5 minutes. And now everything in there has been exposed to their saliva. Throw it away. Good. Okay, respirations. This is breathing. We don't want to tell them we're counting their breathing, though, because that alters their breathing. So you want to pretend you're taking a pulse. Tell them you're counting their vital signs. Normal is between 12 and 20. In and out counts as 1. So pick a starting point on the clock. Count how many times they breathe until the second hand gets back to that starting point. Make sure you're saying start and stop, so the evaluators start and stop when you do. And then document this one. This is a very easy. This is the most common skill on the exam. This is on, I think, 5 skill sets. 4 or 5. I'd have to look again, but 4 or 5. It's the most common skill. So you got a pretty good chance of getting this one. Yeah, I like that one. You can use an alcohol pad during the test. That makes it a little bit easier. Just put the alcohol pad on their tummy. If they ask why, just say, I need it later, and they'll let you. The evaluators actually like it because they can stay across the room. They don't have to be up right on top of the patient to see the respirations. So you can use an alcohol pad. Range of motion. We've learned 2. We're going to learn another one. Range of motion. We lift the extremities from below with a flat palm. 2 points of support near the joints. Flexion extension is up, down. Abduction, adduction is side to side. And rotation is around. We're going to do however many repetitions are on the care plan. Denture care. This is just like mouth care with an extra step. We're going to take the dentures over to the sink during our opening. Wash your hands. Go get your supplies. And then we're going to get ready to clean the dentures. So we're going to put a a washcloth in the bottom of the sink. Prepare your denture brush by wetting it, putting some toothpaste on it, put it in a basin, bring it over to the sink. Use a paper towel to turn the water on. What kind of water should I use? Cold water. I'm going to put some gloves on, grab the denture brush, brush all surfaces. Keep the dentures in my hand. This does require gloves, saliva, food, ick, dentures, or gloves. So dentures have to stay in my hand. Once they're clean, I can rinse them off, get all the toothpaste off, rinse the cup out, put water in the cup, put the dentures in the cup. Cover it, put it on a paper towel on the bedside table. Then go and do mouth care on your patient. Patient will be sitting in a chair, so we don't even have to get them upright. Good? Ambulate with a gait belt. This is an easy one. We're going to put a gait belt around the patient, check it with 4 fingers, make sure we're using the right body mechanics, help them stand up. Make sure they have shoes on. They will for the test. They'll already have shoes on, but just make sure. When you get them standing, ask if they're dizzy before you start walking. Let them lead, walk at their pace. They should be right in front of you to one side so you can see them. Hand in an underhand grip. We're going to let them walk, turn around, come back to the chair. Make sure they're okay the whole time. When they get back to the chair, let them feel the chair behind them, help them sit down, remove the gait belt. That's it. And we're only walking them 10 steps. It's 5 steps in one direction, 5 steps back. Look for obstacles. If there's any obstacles, make sure you move them before you stand the patient. And we learned how to do a partial bed bath. This is the longest skill. Face to waist, front and back. Face first, no soap. We'll use the leaves method on the face. So eye, entered outer corner, fold that leaf. Eye, entered outer corner, fold that leaf. Face, fold that leaf, nose last. Then you'll wash the front of the torso, one arm and hand. Turn them over, or put the gown on, turn them over, wash the back. Give them a little back rub, tie the gown, clean up. It really is an easy skill. It's just long. Oh, it's long. But it's not hard. You already know all the principles involved. That was a review. I'm not going to do that again, though. So today we have, I think, 4 skills that we have to learn. 3 that's on our syllabus, and we're going to bring in the last range of motion that we missed from class 2. So 4 skills. And Monday, we have the final 3. Monday, you should have about an hour and a half of practice time in class. You'll have quite a bit of practice time. All right, so let's learn how to transfer out of bed and into a wheelchair. If you look on page 72 of your book, you can see the overview of this particular skill. Hey, Jake, can you get me the wheelchair, please? Okay. Over here, please. Thank you. You'll probably need to do some close-ups eventually. All right, so when you're looking at page 72, down the side here, you've got our principles that govern this skill. There's nothing new to learn. We know everything that we need to know. They're all spelled out here for you for easy reference. Down here, somebody with your level of experience should be able to get somebody out of bed and into a wheelchair in 11 minutes. That is an insane amount of time. That's way more time than you need to get somebody out of bed and into a wheelchair. Up, over, down. They're giving you 11 minutes to do that. So that tells us there's a few other things in there that are probably going to be important. This is going to be a live testing student, one of you. That person will be in bed to start. Well, that makes sense because we're going from bed to wheelchair. and charting is not required for this skill. We look at page 73, we have step-by-step instructions, and we have our care plan at the top of the page. Care plan tells us to transfer the resident from bed into the wheelchair. The resident is unable to walk or take steps. Underline that. Highlight it. Unable to walk or take steps. We're going to come back to that care plan in just a second, but I want to bring your attention to this little graphic right here. This graphic of the bed with the guy sitting on it and the wheelchair next to it. Do you see how close that wheelchair is to that guy? That is still too far away. That is still too far away. Because our care plan tells us that the patient cannot walk or take steps. If I pick that guy up and pivot him around so his backside is by the chair, they're still not going to be able to feel that chair behind their legs. And their body will try to take a step back, but our care plan says they can't. So that's going to lead to a fall. So this graphic here is actually still too far away. You've got to get that wheelchair close enough that when you spin that patient, that wheelchair is against the back of their legs. That's how close it's got to be. Good. So I should basically be able to fit a piece of paper between the wheelchair and that guy. That's the number one error that's made on this skill, is the wheelchair is not close enough before you lift them.
So it should be directly, basically touching the face of the word of the bed.
Do you see how it's at an angle? That's what we want, a slight angle. So when I lift up and turn, there's the wheelchair, and we're going to sit them down. Okay, so it's going to be at a slight angle. You don't want it straight on because then you got to spin them all the way around. That's no good for your knees or back. You don't want it straight, like this is straight, because when I pick them up, I've got to spin them a little too much. Okay, if I've got it at a slight angle, turn this around. If I've got it at a slight angle, like this, it's up and down. It's a whole lot easier. This straight actually makes it hard to get it close enough. Okay. Angled is what we want. All right. It tells us our patient can stand with support. So we're not supporting this patient's whole weight. They just can't take steps. A gait belt or transfer belt is required to transfer the resident, and after, the resident will stay in the room. Let me ask you guys a question. If I put you in a wheelchair and I was going to leave you in a room, would you want to stare at a blank wall? No. It would actually feel a little bit like a punishment. I don't know how, most of you guys are young, but it used to be when we got in trouble, they would put us in a corner and we had to stare at a wall. Right? So that's a punishment. So at the end of the skill, when I get the patient into the chair, I can't leave them there. I need to turn them around so they can look out a window, look at a TV, watch people in the hallway. They got to have something to look at, not a wall. So even though our patient will stay in the room, we still have to do something with them. Make sense? Good? Okay. All right. So shoe rules are going to apply here. If the patient's feet hit the floor, we're going to talk about their shoes, but they're in bed. They're not wearing shoes. So when we get the patient sitting on the side of the bed, what do you think we need to do? Put shoes on them. So for this skill, you will actually have to put shoes on the patient. Now, do you guys remember class 1? I told you during the test, the evaluators are going to check you in, make sure you're you, look at your 2 forms of ID, and then they're all going to, the evaluators are going to go out of the room and be gone for like 20 or 30 minutes. And they're going to pair you up with somebody else during that time. And they're going to come in and divide you up into groups of 2. You guys remember that? So let's say that you have transfer from bed to wheelchair. I know that's one because it's actually coded into your Prometric ID number. I know what skills you have. So I know that you are going to have to lift somebody up and put them into a wheelchair. I need to find somebody your body size or smaller. So I'm going to look at everybody else that came in that day, and I'm going to kind of have some ideas. But I'm going to look at those particular people and see, does anybody have, any of those people have on slip-on shoes? Okay, slip-on shoes that are easy to get on and off. And if I can find somebody your body size or smaller with slip-on shoes, that is your patient. So I wouldn't want to pick you, although you would be good as a body match. Those shoes look like they're a nightmare to try to get on and tie, right? They're high top Converse type shoes. So I would not pick her. I would probably go with her. Okay. You guys see the evaluator's kind of mindset there? And this is why it takes them a little bit of time to pair you up with other people, because they have to look at the other person's skills too and make sure that you're a good fit for them. So it takes a little bit of time. So when you get the patient on the side of the bed, that patient will need to have their shoes put on. During the test, try to wear shoes that are a little bit easier to get on. Okay, just in case. This skill and foot care, people have to put your shoes on. Don't wear sandals though. Have to be closed-toed, full shoes. All right. So we've got the patient sitting on the side of the bed. We're going to put the shoes on before transferring them. And remember, slipper socks are not enough. Now, there's a school here in Florida that this just cracks me up. A couple of years ago, there was a instructor there that got the bright idea to put the patient's shoes on in bed and then, swing them around so they're sitting on the side of the bed. How many of you guys put your shoes on while you're laying in bed? Yeah. Yeah, it's going to get your sheets all dirty with whatever's on your shoes. Right. Sitting on the bed on the floor. Yeah, but this teacher was teaching her students to put the shoes on while the patient is laying in bed before they swung them around to sit on the side of the bed. And don't do that. Don't do that. Shoes don't belong in the bed. Those students didn't do really well, and she finally learned and figured out the right way to do this. Once we have the patient sitting on the side of the bed, I'm going to show you how to do that, how to swing them around so they're sitting on the side of the bed. Once they're sitting on the side of the bed, we're going to put that gait belt on. We already know how to do that. Check it with 4 fingers. And then we're going to make sure those feet are flat on the floor. Flat on the floor. So our patient's sitting on the side of the bed with the gait belt, shoes on, feet flat on the floor. We're good to go. We're ready for the wheelchair. Now, let's talk about the wheelchair. Oh, we're going to go through this. These are the old slides. I haven't got the new ones up yet. So we're going to count to 3 before we lift them. We're going to stand at that oblique angle that we used for gait belt before we stand them up and transfer them. Before we sit them down in the wheelchair, we're going to make sure that they can feel that chair behind them. And remember that they cannot walk or take steps. So let's talk about the wheelchair. So this wheelchair is similar to the one that you'll be using in the test. Now, there's lots of different types of wheelchairs out there, lots of different makes and models, but they all work pretty much the same. Most wheelchairs are folded for storage. So to fold a wheelchair up, I just lift up on the center of the seat and the 2 sides go together. To open a wheelchair to use it, lift the back wheels off of the ground, less friction, makes it easier to open, and just pull the handles apart. That's it. That's all you have to do to open and close a wheelchair. Now, these wheelchairs are designed to roll. That's their whole function. If I wanted the patient to stay still, I wouldn't put them in a wheelchair. I would put them in a regular chair at the side of the bed. These are designed to roll, which means they're going to be taller than other chairs, because the whole point is we want their feet off the ground so we can push them somewhere. Let me go. Where is it? We're going to come back to these in just a second, but let me show you this. this slide right here. So do you see how much taller this wheelchair seat is than a regular chair? This is on purpose. But this has a very specific effect on the patient if we don't pay attention to it. And that's why I want to bring this to your attention. Because these wheelchair seats are higher, that chair, because the legs are going to dangle, that chair edge, this edge right here of the wheelchair is going to bite into the backs of the knees. Now, these are the blood vessels in the back of your leg. This is what they look like. And we have bones and muscle. So remember gravity. Bones and muscle are going to press down and they compress these veins and arteries, squish them together. So not much blood flow, which means that if we let the legs dangle in a wheelchair, we end up, you see that seat pressing into that area, we end up with swelling in the legs. We talked a little bit about diabetes. Do you guys remember the diabetes lecture? I told you one statement. When blood slows down or stops, it clots. This blood has slowed down because we squished the blood vessels. So what is this patient at risk for? Blood clots. So when you put a patient into a wheelchair, you have to use the foot pedals. Have to. Now, about, I don't know, maybe a year and a half ago, I was actually in a nursing home facility in our area. I went in to talk to a director of education there. And as I was walking down the hallway, I saw at least 6 patients sitting in the hallway with their feet dangling on a wheelchair. That is a huge risk. These are CNAs that do not understand that risk. The foot pedals have been misplaced. They never went and found them. They didn't care about them. And they now have their patients at risk for blood clots. Does that make sense? All right, so here's the problem. Jake, I need a close-up of the bottom half of the wheelchair, please. That's good. Right there is good. All right, so let me show you why this is an issue. These leg rests, they just snap into place. And the foot pedals just fold down to hold the feet. Now, these leg rests, there's nothing that's really keeping them on this wheelchair except these 2 little pins. So they come off very easily. It's really easy to take these off, clean them, throw them in a room somewhere, and now they're lost forever. So we end up with a whole bunch of wheelchairs and no foot pedals. If you're going to use a wheelchair, you have to use the foot pedal. Go find them. The way that they go on, you see these 2 little holes here? Those 2 little holes, let me go here. These 2 little holes at the top. Let's see if you can, there we go. Right there. Those 2 little holes right there are going to fit on these 2 little posts. So let me see if I can, they just go right on those 2 little posts. I can't see from my angle here. Just like that. They just set in place. So they're really, you know, I mean, it's really easy to lose them because there's nothing like locking them in. Thanks. They just, these are the posts, these are the holes, and the holes just go on the posts. So if you're working with a wheelchair that doesn't have the footrests, you can't use that wheelchair. Now there is a different type of wheelchair though that doesn't have footrests. It's called a companion chair, and you can tell the difference because it doesn't have big wheels. Wheelchair, wheels. Companion chair has 4 of these little tiny wheels, the ones in the front. And that one is lower to the ground. So when you put a patient in a companion chair, their feet are flat on the floor, just like a regular chair. And that patient's able to kind of pad around and move themselves all over. It's got 4-wheel drive. It's easy to maneuver. So companion chairs don't have rests. Wheelchairs do. Do you guys understand the difference and why it's important? Okay. So let's go. Okay. So we're going to get the patient sitting on the side of the bed. I'll show you how to do that in just a few minutes. We're going to get the patient sitting on the side of the bed, ask if they're dizzy, get their shoes on, put the gait belt on, and we're going to bring that wheelchair close, because as we do all of those things, we don't want this wheelchair in our way. It's going to be kind of out there, because I've got to get the patient swung around to sit on the side of the bed. If the wheelchair is right here, their legs are going to hit it. It's going to cause injury. So I need that wheelchair kind of out away, within reach, but not so close that it's in my way. Get them sitting on the bed. I got to have room to put their shoes on. I got to have room to put the gait belt around. I got to have room to do all that. Now, once I have the patient ready to transfer, then I'm going to bring the wheelchair in super close. Super close. And now we're ready to transfer. But if I try to transfer the patient into the wheelchair like it is now, that wheelchair is going to roll away because I did not engage the brakes. So let's talk about brakes. Brakes are very important. The way a brake on a wheelchair works is it's this metal bar here that bites into the wheel to keep it from rolling. That's all a brake is. It just bites into the wheel to keep it from rolling. Now, this particular wheelchair, this is the locking mechanism. This wheelchair, when you pull the lock back, it engages the brake. There are other wheelchairs that require you push the lock forward to engage the brake. There's no right way, but you got to figure out how to engage the brake of the one that you're actually using. So Jake, can you close in on the brakes, please? So this picture is actually this wheelchair. So we're going to push forward. Yeah, everything that you see here is stuff that I created, I took. So, okay, that's right there. Perfect. So to engage this brake, you can see right here, you can see this bar is not touching the wheel. When I pull this lever back, now you can see that bar is pressing into the wheel and the brake is engaged. We want the brake engaged before we put somebody into the wheelchair or before we take them out. Now, when we're ready to move them, we're going to unlock the wheelchair to move that bar, and that allows the wheels to roll freely. Good? Both sides. Both. Yep. I just showed you on that one side. So here's the wheelchair lock on this side. Good question. All right. So this is why we have to lock wheelchairs when they're not in motion. The only time a wheelchair should be unlocked is when it's not in motion, or I'm sorry, when it's in motion. If it's not in motion, it should be locked because floors are rarely completely level. If you look at the light pattern on this, you can actually see this floor is not completely level. If we have a 150-pound patient in a wheelchair and the floor is not level and it starts to roll, it's going to pick up momentum. And the only thing that's going to stop it is whatever it runs into. That's a safety concern. So when we leave a patient in a wheelchair, it should be locked. Good? Make sense? If they're capable, they can unlock it, go wherever they want to go. It's not a restraint. If they can't go where they want to go, and you leave them in an unlocked wheelchair, they're unable to stop it. They're unable to see to their own safety. This is even worse in hospitals with wooden floors. Like really old hospitals that have wooden floors, their floors look like that. It can get really bad. I don't even know if we have any left in America There were, I think, 3 or 4 a couple of years ago, but most of them have been replaced by concrete structures because of the fire hazards. So let me explain to you just how important wheelchair locks are. The largest negligent verdict in Florida had to do with a wheelchair. Largest monetary value negligent case in Florida was all about a wheelchair. And in this situation, a dementia patient was strapped into a wheelchair. Strapped into, what does that tell us? That's a restraint. Can we use a restraint without a doctor's order? Even for safety? Nope. So problem number 1, dementia patient strapped into a wheelchair with a seatbelt. This dementia patient was able to access a stairwell, concrete stairs. So that door was unattended and unalarmed or propped open in some way. This is a safety concern with dementia patients. So this dementia patient is not able to see to their own safety. That's why they're in a facility. The whole purpose of putting a dementia person in a facility is not to make it easier on the family. They'd rather have the patient home, I guarantee it. It's because they can't be vigilant 24 hours a day, 7 days a week for the patient's safety. A dementia patient is put into a facility for safety. That is our responsibility. And we failed this person. That door was propped open or unalarmed. That patient was able to get into the stairwell and they fell down that flight of stairs, strapped into a wheelchair, and ultimately died. Ultimately died. And the family got tons of money for it. Yeah, absolutely. And they now have nightmares every night about how she died. Did we do our jobs? Help isn't help if it doesn't help. And we did not help in this situation. So we have to be better than this. Wheelchairs should be locked when they're not in motion. So remember, they're not a restraint. Patients can unlock the wheelchair, go anywhere they want to go. Yeah, we already know that. Okay. We talked about this already. So this is what the inside of your veins look like, by the way. I don't know if you guys know this. So this is pretty cool. Your heart pumps blood, and it has to pump blood to your toes. So your heart has to pump hard enough to get the blood to your toes. That's cool. But gravity is going to help it out because gravity is going to pull that blood down. So yeah, it doesn't really create a whole lot of work for your heart because gravity is going to help out. The problem is that same blood has to get from your toes back to your heart. Now that's much harder because it's fighting gravity. So, and there's no pump to do that, right? We have to use whatever the heart is left over. So inside your veins, particularly the ones from your legs, inside your veins are little valves, and this creates a ladder system. So when your heart pumps and it pushes out that wave of blood and the blood goes to your toes, as it comes back up, this blood goes into another chamber. And the next pump, that blood advances to the higher chamber. And the next pump, that blood goes up again, right? So we have these valves in our veins that keep the blood moving up this ladder. Otherwise, the blood would just fall down to your toes and stay there forever and we'd all be dead. Wouldn't help us. So these little chambers. Well, the problem is that that valve, when you squish it, it really leaves us open for blood clots because there's not much room there. It's literally closed. It's a valve. When you squish that valve, you can't get any blood through it, and then we get blood clots. That's why blood clots in the legs are more common than blood clots anywhere else. If you have a patient sitting in a wheelchair for a long period of time, we need to be changing their position to relieve that pressure and reduce the possibility of blood clots. So getting that patient up and moving is important. Having them kick their feet or march in place, bring their knees up, or, even getting them back into bed to stretch out, something to allow that blood to move around. So you're probably going to have something on your care plans about your patients in wheelchairs having to have their position changed every 2 hours. Pretty cool. Okay, so 2 parts to this system. We have the leg rests and the foot pedals, and this is what I was showing you earlier. When you get a chance, Jake, zoom into the bottom, please. I know you're typing there. Okay, that's good. All right, so this is the leg rest part, the part that swings out and locks in place. And it just locks in with a little clip back here. To unlock it, now that it's locked, I just pull on the catch behind and it swings out. So leg rest locked in place and unlocked. Once I get the leg rest locked in place, this part is the foot pedal. So it just folds down to support the foot and folds up for storage. When we have a patient in the wheelchair, we want both leg rests in the forward position, both foot pedals down, and the wheelchair locked. So this is how it should look with somebody in it. If I'm going to get somebody out of it or put someone in it, this whole thing has to change. So I'm going to lift the foot pedals up. I'm going to release the leg rests using the catch and get them completely out of the way before I lock that wheelchair in place. I need a wide opening for the patient to get in and out. Good? Let me explain to you how important this is. All right, Jake, you can restore me whenever. There's 3 positions for a wheelchair. This is what it should look like when it's in use. Leg rests out, foot pedals down. Patient's in the wheelchair. This is what it should look like when it's being stored. We want those leg rests forward so they don't swing out and injure somebody while we're rolling it somewhere. So during storage, when we have it all folded up, those leg rests should be locked so they're secure, just like this. When we're transferring in or out, your wheelchair should look like this, wide open, nothing for them to trip over. You might have a test question on the written test that asks you what position should the wheelchair be in during transfers. That's a possible test question. Okay, good. So this is why foot pedals are important. This is also why, let me just preface this. You know how I said that you can't do anything that you haven't been trained to do? Remember how we talked about that, right? This is why. This lawsuit in particular is why. And I really feel bad for this healthcare worker. I really do. Because she just thought she was doing the right thing. She thought she was doing a good deed. So let me explain to you this scenario, what happened here. Older lady and her daughter, oops, I keep forgetting to turn my ringer off. Older lady and her daughter go into the hospital to have some x-rays done of the older lady's leg. And the older lady is in a wheelchair, while she's there because she's having trouble walking. It's very painful. So they got her in a wheelchair. They take her back, get her x-rays. They bring her back up. And the daughter goes out to get the car and bring the car around front. They called for a transporter. Nobody came. So the old lady is sitting in a wheelchair just waiting to go out. The daughter's car is right there at the front door. They can see it. They're waiting. And the receptionist who was sitting at the front desk feels really bad. And she's like, okay, the transporter's not coming. I'll take you out to the car in the wheelchair. No problem. I'll help you. Doesn't think twice about it. So she gets her out to the car, but she had not been trained on how to use a wheelchair. And she couldn't figure out how to get the leg rests out of the way. So she just told the lady, just step over the leg rests to get into the car. Well, the lady already had an injured leg, and during that process fell and broke her leg. Does she get to go home? No. Now she's going to be admitted. So what should have been a very simple routine process, get them out of the hospital and into the car. I mean, it's like easy. Because the receptionist did not know how to do it properly and understand the safety concerns here, the patient got injured. And they sued the hospital. And they won. Now, I really feel bad for this healthcare worker because all she was trying to do was help. But is it help if it didn't help? She lost her job. She lost her job. And she had been there like 22 years. She lost her job. She was a receptionist. She had no license. She was a medical receptionist. I feel bad for her, but should she have done a job that she wasn't trained to do? Nope. Nope. Good? So, foot pedals up, leg rests out for all transfers. The way that we get a patient sitting on the side of the bed is actually way easier than you think it is. And you can turn somebody bigger than you with very little effort. So the way that we do this, and I'm just going to demonstrate on her real quick. First, make sure they're dressed, please. Okay, somehow. So we're going to uncover them and scoot them toward us, because scoot. We're going to scoot them toward us. So I'm going to use a wide base of support, and I'm going to kind of anchor myself against the bed because I need some torque here. So I'm going to kind of anchor it, make sure the bed is locked. Otherwise, everybody's going rolling. Scoot toward me. And then I'm going to pivot her so she's sitting on the side of the bed. To do that, I'm going to put this arm underneath her shoulders. And I want this hand under this shoulder, not just a little bit. I need under the shoulder. We're going to get close. Hope you had your Tic Tacs. This arm goes over the legs. Now, this is the one that most people mess up. They go under the legs. I'm not doing a honeymoon carry. Under the shoulders and over the legs. So when I do that, when I go under the shoulders and over the legs, if the patient crosses their arms over their chest, it makes it a little easier just to keep those arms controlled. But under the shoulders and over the legs, and then it's just a simple pivot. Okay. Whoa, lady. Privacy. All right, so that's how you pivot a patient to sit on the side of the bed. Once you get them sitting there, ask if they're dizzy, put their gait belt on, put their shoes on, and then get the wheelchair close. Lock it in place, make sure the foot pedals are up, the leg rests are out, lock it in place, and then we're going to do the actual transfer. You know how to do the transfer already because it's the same thing we did with gait belt. 1 foot beside the patient, 1 foot in front of their feet, reach around to the back of the gait belt, their hands on your shoulders, on the count of 3, lift. 1, 2, 3, just like gait belt. But instead of stepping back and letting them walk, we're going to stay there and hold the patient. Pivot them around. When they feel the chair behind them, we're going to help them sit. That's it. Bless you. So, bless you. So learning about the wheelchair takes way more time than doing the skill. So pivot them, gait belt on, shoes on, hold the gait belt, put their hands on your shoulders. On the count of 3, lift over. When they feel the chair, sit them down. Then we can unlock it, spin them around, get the leg rests out, the foot pedals down, lock it in place, and do our closing. That's the whole skill. Whole skill. Make sure they're sitting in the wheelchair appropriately at the end. So step by step, we're going to pivot them, get their shoes on, Get the wheelchair close at a slight angle. Make sure the brakes are engaged. Oops, nope, not brake, not yet. Apply the gait belt. Check it with 4 fingers. Brace the patient's feet. Use proper body mechanics. Pivot the patient smoothly. Make sure they can feel the wheelchair before we sit them down. Position their feet on the foot pedals. Make sure the wheelchair is locked and facing forward. Remove the gait belt and ensure they're positioned properly. Do your closing, and that's the skill. So we're going to go ahead and watch the video on how to do this because it's got really good close-ups. This was a heck of a video to edit. We did this skill. I had 24 clips that I had to put together for this skill. We did the skill itself 6 times from different angles. And then I did close-ups of the brakes and the shoes and everything. So this was an editing nightmare, but it came out really, really good because you can see each one of those steps in super close up. Okay. So Jake, go ahead.
Hello.
Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Would you like to get out of bed and into the wheelchair?
Yes, that'd be great.
Okay, I'll be happy to help you with that. Let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll grab the gait belt. And I'm going to bring the wheelchair within reach, but not too close to the bed. All right, Mr. Jones, I'm just going to remove your sheet. We'll pull it all the way to the end of the bed. And I'm going to help you sit up on the edge of the bed. So to do that, can you scoot your body toward me? That is locked. You're going to cross your arms over your chest and relax. I'll do all the work. I'm just going to pivot you around so you're sitting on the side of the bed. Please let me know if you get dizzy or unstable at all. So I'm going to wide base of support, leaning against the bed, making sure the wheels are locked. I'm going to place one arm all the way under the shoulders and the other arm over the knees, bending at the knees, not the waist, and we're going to pivot. 1, 2, 3. Good?
Yes.
Okay, you can relax your arms. I'm going to help you put your shoes on now. Okay, first shoe and the second shoe. And are your feet flat on the floor?
Yes.
I'm going to place this gait belt around your waist, making sure that it's not twisted or kinked. And we'll secure it by sliding the gait belt into the first guard, pulling it so that it's snug. We'll check it with 4 fingers, and then slide it through the second guard. I'm going to bring the wheelchair close at a slight angle, almost touching the patient. And we'll lock the wheels. All right, Mr. Jones, can you bring your feet together and back a little? Are your feet flat on the floor?
Yes.
You're going to place your hands on my shoulders. I'm going to lift you to a standing position, pivot you, and when you feel that seat behind your knees, I want you to say sit, and I'll help you sit.
Okay.
Okay, you're going to place your hands up here. And on the count of 3, we're going to lift and pivot. 1, 2, 3. And we'll remove that gait belt. Okay, and I'm just going to bring the gait belt behind you and turn you around to get your feet onto the foot pedals. So we're going to turn around. I'm going to bring the first foot pedal forward. Make sure it locks into place. And then place the foot on the foot pedal. We'll then lock the wheelchair. I'll lock this side, support your leg, bring the leg rest and the foot pedal, and support the foot. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light. Here's your call light. If
Thank
you need
you.
anything at all, just press that red button and somebody will be happy to come help. I'm going to open the curtain and go wash my hands. On the way, I'll return the gait belt to storage. After washing my hands, I'll think about my skill, make any corrections, and tell the evaluator my skill is done. All right, any questions on that one? That's a pretty easy one. They give you 11 minutes. It does not take 11 minutes to do that skill. Don't rush. That's where most people trip up on this one is they try to rush. Don't rush this one. But it's not a hard skill at all. No questions? Okay, let's go ahead and take our break. I know we're a little late on break. When we get back, we're going to get into feeding a resident. This has a little bit of a lecture I have to give you. It's not just as simple as feed somebody. There's some information you need to know about calculating feeding percentages, why this skill is different from other skills, some things we have to talk about. Then we're going to do Peri-Care. Peri-Care is a long skill, but you already know what you need to know to do it. We're going to use the leaves method that we learned on Monday. But we do have to learn about incontinence and what that means to the patient. So a little lecture for the next one and the one after that. The last one, which is range of motion, you guys already know how to do that. I'm just going to show you the video. We're going to read the care plan. You'll see the video. That'll be a pretty easy one. You should have, hopefully, fingers crossed, about 45 minutes or so, 30 to 45 minutes of practice today. On Monday, you're going to have much more. You'll have closer to 2 hours. Okay, good? Let's go ahead and take a break.
You were on slide 69.
Yep. Thank you. All right. Thank you, Jake. Efficient you are. All right, so the next skill we're going to learn how to do is feeding a resident who's sitting in a chair. If you look at the overview page, there's nothing new to learn here. We know everything we need to know. We know all of the principles. This skill should take somebody with your level of experience 9 minutes or less. Spoiler alert, you're only giving somebody 4 bites. That's it. 4 bites of food. It is a live testing student skill, so you might be fed for the skill, but you're only eating 4 bites. You are going to eat like you eat. Do not turn into a slobbering 2-year-old. This is a real, real person eating skill. A person will be in a chair, but 9 minutes is way longer than you need to feed somebody 4 bites. All right. Here's our care plan on the top of page 109. It says, feed a resident a snack who is unable to feed him or herself. It doesn't say they have swallowing difficulties. It doesn't say that they're paralyzed. It doesn't say they can't use their hands. Just for whatever reason, they can't feed themselves today. So don't make this patient into something they're not. It says the resident is sitting in a chair in an inappropriate position for eating. You might want to underline that because our care plan is telling us they're not sitting up straight. What do we want to do? Yeah, get them sitting up straight. So just ask them, hey, are you sitting up? Can you sit up? Please sit up. Whatever you need to do, but get them sitting into a sitting position. It tells us to document the intake on a food and fluid intake form. You can see a sample of it here. The bigger version is on page 169 if you would like to see the full size version of the documentation sheet they'll use for the exam. Down here are your supplies. You need a towel. This is going to be a clothing protector. We need a hand wipe. Food tray will already be prepared and on the table for you. And you'll need a pen and a documentation form. They will give you that at the beginning of the skill. Put the documentation form in a visible place. So at the end of the skill, you see it and remember, oh, I have to document. So this skill is unique because it doesn't follow our rules. It just doesn't. It's unique. We don't use a barrier on the table. Our tray is our barrier. We don't need to go get another barrier. So you don't need a barrier for this one. You're not going to close the privacy curtain. And that's because eating is a social event. People gather in groups to eat. They have conversations. Imagine, let's say you walk into, let's pick on Golden Corral next door. Let's say you walk into Golden Corral at lunchtime. There's 50 people in there. Is it dead silent? No, people are having conversations. We don't talk with our mouth full, but that doesn't mean you don't talk while you're eating. While you're chewing, somebody else is talking to you. While they're chewing, you're responding. You have conversations while you eat all the time. Around the dinner table, you have conversations. Your patient also needs to have a conversation. You're actually graded on them having a conversation. So we have to keep this in mind. Don't close the privacy curtain. It isolates the patient. They won't eat as well. We found this out during COVID. During COVID, we closed down all long-term care facilities. Families were not allowed in. The only people that were allowed in were staff. And we didn't let our patients go to the dining rooms to eat. We made them all eat in their rooms, isolated. It was astounding how much weight patients lost during COVID. It was when they went back and looked at it, it was an inadvertent study. We didn't mean to study this, right? We didn't mean to do this experiment. The experiment happened, but then we had to go back and figure out what can we learn from this event. And what we found is that we lost just as many people from failure to thrive as we did from COVID. Socialization is a huge part of the person experience. the human experience. And eating is one of the times when we really rely on socialization. Have you ever gone into a restaurant, somewhere to eat, a diner or something, and saw an old person sitting there alone eating? What is your initial reaction? Aww. Right? We all have that same reaction. Oh, that person's alone. And yet in a long-term care facility, we don't think anything about sitting in front of them and eating and feeding somebody and watching TV, not engaging with them. We have to be careful and not let the setting confuse what's important to humanity. Does that make sense? Okay. So we're not going to close privacy curtain. You have to sit down when you, it's the only skill that we require. You pull up a chair and sit. And that's because if you stand over somebody and feed them, it makes them feel inferior and they won't eat as well. They're going to feel rushed. They're going to feel like an imposition. And you actually have to have a conversation. You have to. Doesn't have to be a real one. You can make something up, but you have to have a conversation. So you can say something like, they're showing a movie on the big screen later. Would you like to go see it? Or, oh my gosh, the bingo jackpot's up to $2.25 this week. And Martha thinks she's going to win it. Are you going to bingo this afternoon? I can't wait to see what happens. I'm making that up, but for the test, but in real life, have a real conversation. I always like to talk about sports with men. What's your favorite team? What's your favorite sport? And if I know a little bit about, the game, I'll talk, hey, did you see the game last night? With women, I like to talk family, right? I'm going to lean into their strengths. I also look around for things in their environment that can give me a clue about things that they're willing to talk about. So people will talk about pictures that are posted in their environment, family, picture of themselves when they were younger, paintings. Where did you get that? That's gorgeous. Look around their environment for clues. So our skill-specific steps here is that our patient must be sitting fully upright. We know they're not because our care plan told us that. We have to offer a hand wipe and a clothing protector. We're going to offer both. They don't have to use either, but we're going to offer both. We are going to sit down while we feed them. We're going to offer a drink before feeding and every 2 to 3 bites. We're going to offer small bites. The spoon should be less than half full. And while we're doing that, we're going to be having that conversation. We're going to let them lead with the eating. So let them chew and swallow and, wait until they kind of indicate they're ready for it. Don't just shovel stuff in as quick as you can to get it done. Take your time, have a conversation, encourage the patient to eat, leave the area around the mouth clean, and of course, document. So we want to offer a clothing protector and a hand wipe. Now I'm going to tell you, not everybody's going to want a clothing protector. My grandmother, prim and proper, not a chance. She would not take a clothing protector at all. Me, I need one. I wear everything I eat. Everything I eat. So you offer me a clothing protector? Yeah, please. Because I know I'm going to wear it. Hand wipe, we're going to offer. Now, not everybody's going to use it, but most people will. Because even though our patient is unable to feed themselves, it doesn't say they're paralyzed or they can't use their hand. And if food starts to fall out, what are they going to do? Yeah, they're going to bring their hands up to their face. Do we want dirty hands near the holes? So offer a hand wipe at the beginning. We're going to sit while we feed them. We're going to offer a drink every 2 to 3 bites before and after. Now, everybody has different preferences with this. My aunt was a model when she was growing up, and she got in the habit when she was very young to drink a whole glass of water before she ever ate a meal. And it worked for her. The water would fill her up and she would eat just very little. It doesn't work for me. I've tried it. It does not work. Does not work. So a lot of people will drink before they eat. Now, some people like me drink while they eat. I don't produce a lot of saliva, so I have to have constant drinks as I'm eating for the food to, be able to work properly. Now, there's some people who don't like to drink while they're eating. because they don't want to fill up on liquids. They'd rather have the food, please. So they will drink after they eat. So everybody has different preferences, and you probably never really stop to think about it. Don't assume the way you eat is the way the patient eats. This also goes not just with drinking, but with eating. And these are things you probably haven't thought of. Everybody has different eating preferences. So some of you don't like your foods to touch on your plate. Anybody? Yeah. Okay. Some of you like your corn and mashed potatoes mixed. Some of you don't. Some of you will take a little bit of several things on your fork at the same time, like meat and mashed potatoes. Some of you are like, oh, no, that does not work for me. Some of you eat your salad before the meal. Some of you eat your salad with the meal. Some of you eat the salad after the meal, and some of you wouldn't eat a salad if it grew legs and clucked. Everybody has different eating preferences. We need to find out what our patients' eating preferences are and don't assume they eat the same way you do. A very common one is that a lot of people will eat all of one thing on their plate before they move on to the next thing. And they'll kind of go around in a circle. Some people will eat a little of this, a little of that, and just jump all around willy-nilly. Everybody's a little bit different. So we need to figure out what they want. But let me tell you a funny story about this that really illustrates this concept. Many years ago, I was a hospice nurse, and there was a nursing home that I was assigned. I went into every single day, saw the same patients in the nursing home. They were on hospice, but living at the nursing home. And I was taking care of this one lady, and she had end-stage cancer. She had had a stroke. She was nonverbal, right-sided paralysis, and she was in the dining room on this particular visit, and I walked in, and she was very with it, but she couldn't speak, and she had end-stage cancer. But she's in the dining room, very expressive, even though she couldn't speak. She could kind of let you know what she was thinking. And I walk in, and the CNA is sitting at a table with several residents, and she's feeding. And I said, hey, Miss Mary, what's for lunch today? And Mary, the patient, I'm calling her, it wasn't her name, but Mary looks at me. She looks at the CNA, and then she just rolled her head and her eyes, and it was very obvious she was displeased. So I looked at the plate, and it's this big gray glop of goo, right? Just this gray whatever. So I asked the CNA, I'm like, what's lunch today? She says, oh, they're having Salisbury steak, mashed potatoes, and beets. Okay, but what's that? She said, Salisbury steak, mashed potatoes, and beets. I just mix it all together. And I'm like, would you eat Salisbury steak, mashed potatoes, and beets mixed? And she says, no, that's gross. Then why are you serving it to her? Oh, well, it's pureed. It doesn't taste like anything when it's pureed. No, pureed has all of the taste, just none of the chew. And she says, oh, that's gross. And then tried to put another spoonful in the patient's mouth. It's like, do you connect the dots, please? Take that tray back to the cafeteria, go get her a new one. She's not going to eat that. And Mary was just like, rolling her eyes. For all she was worth, she's just trying to let everybody know that this is not right. Don't make assumptions. Please don't mix stuff that don't deserve to be mixed. Beets don't get mixed with anything other than maybe the garbage can, right? Be careful there. But I'll tell you the one that really surprised me. I wasn't ready for this one at all. We had an older lady. Now, this is 30 years ago. We had an older lady in the nursing home. She was in the dementia unit of the nursing home, and she was just like a little Southern belle. And all of maybe 90 pounds, teeny tiny. And anytime that we would serve a sandwich, a hamburger, a hot dog, a slice of pizza, a sandwich of some sort, she wouldn't eat. And this was consistent. She would eat anything off of a spoon or a fork, no problem, but she wouldn't eat anything if you brought it to her face. So I asked her family, you know, hey, do you know anything about this? And her daughter goes, oh, yes, that's actually a Southern thing. And I'm Southern. I've never heard of this. What do you mean it's a Southern thing? She said, in polite company. Now, this lady literally had grown up on a plantation. She was Southern. In polite society, that's how it started. I'm like, oh my. In polite society, young ladies never took a bite out of food. Everything had to be cut and presented on a utensil. You did not pick food up and bring it to your mouth. I had not heard that. I had no idea that that was a thing. Now, these older people with that type of upbringing are pretty much not here anymore. You may not see that anymore, but that one surprised me. I wasn't aware of that. So, okay, well, now that I know, we can kind of make accommodations for that, make sure that everything on her plate is cut up, and she started eating. Great, awesome. So sometimes if you make observations from your patient that just don't seem right, normal, what, you know, it's an observation. What do we do with those? Tell them to the nurse, because something that's simple can trigger malnutrition. But that one surprised me. Spoon should only be half full. We're going to feed slowly. We're going to have a conversation. And we're going to encourage our patient to eat once they stop. Now, I'm going to time out from this a minute. And I'm going to talk to all of you as a patient during the test. Because remember, this is a live testing skill. Any one of you might be a patient for feeding during the test. When you're a patient, you're going to get some very specific instructions. They're going to tell you, number one, slouch or slump. So to you, that might be slouching, right? If somebody tells you to slouch, you might do that. But every 10-year-old on the planet eats just like that. So if you've got a 10-year-old in your house, you might not see that as slouching or slumping because that's normal. So that's why the care plan says they're not in an appropriate position. Okay. So they're going to tell you to slump or slouch. The next thing they're going to tell you is only take 4 bites and then refuse nicely. Say, no, thank you. I'm done. I'm finished, whatever. But just 4 bites. It's all we want you to take. Don't keep eating. Okay. So 4 bites is all you're going to take. And the spoon is only half full. So really you're getting 2 spoonfuls of something. Even if pudding is not your favorite, try to choke it down. They're going to give you either a single serve pudding or applesauce cup. That's what they use. And remember, you're only eating 2 real spoonfuls. Okay. So when you refuse, the CNA has to encourage you in some way. So there's 3 that I use. You probably should use at least 1, but 2 would be nice. The first is, are you sure you wouldn't like something else? Because, or I'm sorry, are you sure you're done? You don't want 1 more bite. I always try to get them to take 1 more. I'm part of the 1 more club. Okay, just 1 more. The next thing I'll do is ask them, are you sure you don't want something else from the kitchen? We've all had those days. You make something, you take a bite, you're like, nope, not it. Not what I was looking for. I did that with mac and cheese a couple of weeks ago. I made a box of mac and cheese because I thought that's what I wanted. I took a bite and I'm like, yeah, it's not it. It's not it. So we've all had those days. So let's, you know, your patient isn't making this food. They're kind of stuck with whatever we bring them. So offer them something different. Maybe they want something different. The third thing I will always say is, if you get hungry later, let me know. That lets them know that there is food available so they don't go hungry thinking that it's only meal times. Use 2 of those. Leave the area around the mouth clean and then do your closing. So part of this skill is going to require documentation. And we're going to document on this check-off form. So we're going to check off whether it was a snack or a meal. What does our care plan tell us we're giving them? A snack. So make sure you put a check mark in the snack box. Check or X, it doesn't matter. And then you have to check off how much they ate. So we have to talk a little bit about feeding percentages. And that's the next thing we're going to cover. But to recap here, we're going to offer a hand wipe before feeding. We're going to offer a clothing protector, offer a drink before feeding, and every 2 or 3 bites, we're going to let them lead. Feed slow, spoon only half full, and don't use childlike feeding techniques. No trains, planes, or automobiles. Okay, so here is our what we call quarter scale. If the patient ate everything, they ate 100%. If they ate nothing, they ate 0%. Those two are easy. No judgment there. If they ate it all, if they ate none, those are easy. It's here that we kind of get all tangled up. They're estimates, guys. They're estimates. If they ate about half, 50%. If they ate more than half, but not all, if they ate less than half, but something, they're estimates. Okay, now, you guys got this, right? Okay, let's go back to the test. We have a single serve cup of pudding or applesauce. You gave them 4 half spoonfuls. How much did you give them? 25%. It's more than none, but if you end up with giving them half, you overfilled that spoon. So for the test, what are you going to be documenting? 25%. That's what it should be for the test if you do the skill right. Good? Now, fluids, you got to check a box there. I don't know how much they're going to drink. They may say no to the fluids. They may drink the whole cup because they're nervous and their throat is dry. I don't know. Just document whatever they drank. If they drank it all, 100%. If they drank none, 0%. If they drank half, 50%. If they drank less than half, 25. More than half, 75. You guys got this, right? It's an estimate. Okay. So this is an activity to help us kind of get the hang of this. In order to figure out how much the patient ate, we really have to know what they started with. So this plate has a sandwich, broccoli, and some Jell-O. I don't know anybody that's serving broccoli with a sandwich, but we're going to go with it, okay? Because that's what I learned how to draw. So that's what we started with. So here, this figure here, we ate a little bit of our sandwich, a bite of our broccoli, and a little bit of our Jell-O. So it's not 0. It's not 0. It doesn't look exactly like this one, but it's not half either. So what would we call that? 25%. So let's look at this one. They ate half of the sandwich, half of the broccoli, and a little bit of the Jell-O. What would we call that? About 50%. Here, they ate almost all of it, but not quite. 75. Now, this one's a little trickier, right? Because we're looking for all. There's 2 pieces of Jell-O and a broccoli stalk. We're going to give them credit for 100% here because I don't think broccoli stalks count. Okay? So we're going to give them credit for, see how it's a judgment here? Okay? This is 75. This is more than 75. So let's give them 100. Make sense? Okay? All right. So now we're going to look at fluid intake. So in your book on page, what page is that?
106.
That one? 106. Go to page 106 in your book. This is an activity for food and fluid intake. But I want to talk to you a little bit about intake and output, which is something a little different. So we just used our quarter scale for estimating intake. But a lot of times your patients will be on intake and output, which is a much more scientific measurement. And it's going to deal with liquids. If your patient is on intake and output and we're measuring the liquids that went into the body, we have to know how to convert. So when you go to work at a facility and you go through orientation, they're going to show you their cups. And it sounds weird. But they're going to show you, as CNAs, their cups. They're going to say, this is what we use for a coffee cup. It holds 8 ounces. This is what we use for our water cup. It holds 6 ounces, and you're going to need to know that. Because when you're doing intake and output, and they drank 3 of these cups of coffee, and each one is 8 ounces, they drank 24 ounces of coffee. But we don't document in ounces. We document in cc's or mls. Cc's and mls, same thing, 2 different names. Remember in healthcare, there's 2 names for everything? Cc's, mls, same thing. So we need to know if that's 8 ounces of coffee, how many cc's is that? And to do that conversion, you need to know that 1 ounce equals 30 cc's. So for every ounce, it's 30 cc's. So if we have an 8-ounce cup of coffee, 8 times 30, anybody know? 240. So that cup of coffee is not 8 ounces, it's 240 cc's. If we have a 6-ounce glass of water, how many cc's is that? 6 times 30, 180. That is not a 6-ounce cup, that is a 180 cc cup. Good? So we need to know how to convert. During the exam, you will have 1 math question. You will either have to convert ounces to cc's, or you will have to add up the amount of cc's the patient took in that shift to get your total intake for the shift. Page 106 has an activity there for you. Now, I want to bring your attention, at the bottom of the second column, you'll see a little milk carton. Milk carton says, how many ounces? 8 ounces, but next to it, what does it say? 240 mLs. So pre-packaged items. So like that Coke can. Take a look at that Coke can. How many ounces? How many mLs?
300.
Okay. So pre-packaged items will actually have the mLs right on them. So that Pepsi bottle, is that Pepsi? Okay. How many ounces? And how many cc's or mLs? Okay. So what would you document on intake if somebody drank that whole thing? Okay, instead of doing the conversion, because it's telling us how many mLs, what would we document? 591. So if the package tells us the mLs, we use that. If the package doesn't tell us the mLs and we have to use a cup that we just know it's 8 ounces or 6 ounces or 4 ounces, we would have to do the conversion. Make sense? Good? So sometimes your patients will be on intake and output. That means that as CNAs, because we bring the meals and the snacks in, we encourage fluids, we keep track of everything that goes in the mouth, we're going to have to write all that down. We also keep track of the urine that comes out of the body. We're going to have to write that down. Oh. Okay, so metric system. Okay. Fluid measurements is done in liters or milliliters or deciliters. It's going to be based on the liter system, fluids. Volume is cc's. Now, in healthcare, we generally default to volume measurements, cc's, volume. But that volume is made up of liquid. So mLs is appropriate. Okay, so that's a very short explanation, but way back when we first started doing this, cc's was the standard. Then they started bringing mLs in, and now it's very muddy. So we just say cc's are mLs. Okay. So good? Everybody got this? Everybody got, I did have the page up there. Everybody got this? You can do this on your own. In the online course, I have a whole activity on this. All right, so let me bring your attention to page 132 for a moment. This is a lesson on medical abbreviations. And I think we've already talked about this a little bit. But anything that is shaded in gray, you probably need to know. Particularly this one as it pertains to feeding, NPO. Remember, these are not abbreviated English. They're abbreviated Latin for the most part. So NPO means nothing by mouth. So if your patient is NPO, should you be giving them a lunch tray? No. Now, a lot of times it'll say NPO except water. Now, except is actually written, do I have that on here? I'm not sure if I have that on here. Except is actually written with an X and a line over it. So, for instance, right here on the special symbols, you'll see A with a line over it that means before, C with a line over it that means with, P with a line over it means after, and S with a line over it means without. Well, X with a line over it means except. So you'll also often see NPO, X with a line over it, H2O. NPO, X, H2O. That means nothing by mouth except water. They can have water. Or it may say except ice chips. We don't want our patient getting dehydrated. So good? You can take a look at that activity on your own. All right, so here is the documentation form that we use for intake and output. I have a whole lesson on intake and output in your book as well on page 107. You can learn more about intake and output there. All right, so let's go ahead and watch this video. It's like a 3-minute video. Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. Could I ask you to sit up straight before we get started, please? How are you?
I'm good.
Fantastic. Would you like to eat a snack?
Yes, that'd be lovely.
Okay, I'd be happy to help you with that. Let me go wash my hands, get my supplies, and I'll be right back. Okay, Mr. Jones, I'll give you a hand wipe so you can clean your hands before we feed you. Okay, would you like to take the hand wipe?
Yes, please. Thank you.
And go ahead and clean your hands. Thank you very much. I'll dispose of this in the trash. And would you like a clothing protector?
Yes, please.
I'm going to go get one for you. Okay, Mr. Jones, I'm going to take this clothing protector and put it over your chest. This will just protect your clothing while I feed you. And I'm going to pull up a chair. How are you doing today?
Very good.
Wonderful. Would you like a sip of water?
Yes, please.
Okay. And we have cinnamon applesauce. How does that sound?
Great.
Wonderful. Here we go. We're going to fill the spoon less than half full. And do you enjoy sports?
Yes.
What sport do you like?
Football.
Oh, I do too. Did you watch the big game yesterday?
I was so happy my team won.
Oh, it was such a great game. I couldn't believe in that last quarter what happened. Another bite?
Yes, please.
There you go. Would you like a drink?
Yes, please.
Okay. Good?
Yes.
All right. Yeah, my favorite team doesn't win very often. Usually when I'm watching, they're guaranteed to lose.
Usually for me as well.
Would you like another bite?
No, thank you.
Are you sure?
Yes.
Okay. Can I get you something else from the kitchen?
No, thank you.
Okay, if you get hungry later, please let me know.
I will.
Okay. All right, I'm just going to take this clothing protector off and we'll clean your face. I'm going to put this in dirty linen. I'm going to dispose of all the disposables. And we'll return the tray to the bedside table. Just going to move this to the side. And are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light for you. There's your call light. If you need anything at all, just hit that red button. We'll be happy to come help. I'm going to go wash my hands and document. After washing my hands, I'll document the amount of food the patient ate and the amount of fluid that they drank. Once I'm done documenting, I'm going to go wash my hands one final time. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right. Questions? Questions? Feeding is pretty easy. Yeah. Something about feeding, though, that most people don't really think about. Feeding is the hardest skill to be a patient for real, in real life. If you have to be fed, it affects you psychologically in a way that nothing else does. Eating is the first skill you become independent at. You learn how to hold a bottle before you sit, stand, crawl, or walk. You learn how to get food off of a high chair into your mouth before you can even sit up. So you become independent at eating before you master anything else. When you lose the ability to feed yourself, it affects you psychologically. And most people that are fed do not eat well. So they're at risk for malnutrition. So we really want to make this a very positive, welcoming experience for them. Don't rush them, have a conversation, socialize, make them feel like you want to be there. Otherwise, they're not going to eat well. Okay, good. Let's go to page 152. We're going to go over Peri-Care. Oops. And again, if you're looking at the overview here, there is nothing to learn. We have mastered all of these principles. We're going to put them to work in this skill. But let's take a look down here. Somebody with your level of experience should be able to do this skill in 17 minutes or less. That's a long time. Remember, a partial bed bath was 19, so this is just a little bit shorter than that. It's going to be done on a mannequin, not a real person. You will not be a patient for this. Mannequin. That mannequin will be in bed for this skill. If you go to page 153, at the top, we have our care plan that tells us the female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the gown and bedding are dry. That's a miracle. Does not happen like that. If the pad is wet, so is the gown. And probably the bedding too. But we're going to take the gift they give us for the test. They just want to see us do Peri-Care and change the pad. That's all they're looking for here. So we're going to take that gift. Our supplies down here at the bottom, you need to learn your supplies. There are a lot of supplies for this particular skill. But let's talk briefly, very briefly, about incontinence. 5th grade urinary system review. We have 2 kidneys. Those filter blood, take out all the impurities, and create urine. That urine drips down tubes called ureters to the bladder. Bladder's a Ziploc bag that holds that urine until you're ready to get rid of it. You go to the bathroom, there's a little valve here at the bottom of the bladder that stays closed until you're ready to empty your bladder. When you go to the bathroom, that valve opens, the urine comes out, the valve closes again, and you're ready to go for a few more hours. This is a normally functioning urinary system. When your patient has incontinence, what has changed is that valve doesn't close. Everything else is the same. Your kidneys still filter blood 24 hours a day. That urine that the kidneys produce still go down these ureters 24 hours a day, drip, drip, drip. They still go into the bladder, drip, drip, drip. The problem is there's no door at the bottom of the bladder to hold them in, so they come out, drip, drip, drip. So your incontinent patient is going to be wet 24 hours a day, drip, drip, drip. Because remember, your kidneys are working 24 hours a day. Good? Now, the problem is that adults are not like babies. Not like babies at all. A baby, you can put a diaper on them, put them to bed, let them go to sleep all night, and you wake up the next morning, they still have skin on their little tushes because their urine is very mild. Our urine acidity is related to what we eat. And as adults, we eat a lot of acidic foods. It's what makes it taste good. So all of that extra acid is excreted through our urine. So adult urine, very acidic. Baby urine, yeah, they do rice cereal and, mashed up plums, right? It's very mild. Their urine is very just bland, mild. It's not going to burn their skin. Adult urine will burn your skin if you leave it against the skin for a long period of time. So we can't put a diaper on an adult, put them in bed and leave them there for all night because that acid up against the skin will eat the skin. Now, we don't call them diapers. For adults, we're going to call them adult briefs, but the process still has to be addressed. You can't do to adults what we do to babies. Hawa says, thank you so much for your video. It helped me pass the written exam last week, Wednesday. Congratulations. Good job. It's going to contribute to it. It's going to contribute to it. So adult briefs, remember, we don't call them diapers. Adult briefs are going to be used when the patient is out of bed. It's a dignity issue. So if your patient's incontinent and the urine just comes out on its own, we want to collect the urine with an adult brief, but we can't leave it on for hours and hours and hours and hours and think our patient's going to be okay. We're going to need to change that adult brief and clean the skin every 2 hours. Get the skin clean. Now, it's not going to stay that way for very long because incontinence is all the time. Good? Make sense? All right. But let's think about the inside of that adult brief. It's plastic lined, right? Because we don't want the urine to come out. It's going to hold in body heat and block out light. So we have warm, dark, moist, and what grows there? Pathogens. And there's your answer. Okay, so when we have an adult brief on a patient all the time, you're going to get more infections. There's a better way, though. When the patient's out of bed, adult brief. That's the right way to go. But when they're in bed, adult brief isn't always the right answer. Putting them on a pad, leaving them open to air so all of that urine as it comes out just gets pulled away on the pad, allows light and air to circulate. We end up with fewer infections and less skin issues. And that's how this skill is going to start. Your patient is a mannequin with a gown on and nothing else, laying on a pad. And that pad is going to pull the urine away from the skin. But it's going to decrease infections because we don't have the heat and the dark. Make sense? This is called open to air. And a lot of your patients will have open to air while in bed on the care plan. Not all patients are comfortable with this. There are a lot of patients that would rather have some sort of undergarment on, even if it's an adult brief, and that's fine. We treat every patient as an individual, and that's why we have to look at the care plan for each one of our patients. But if possible, open to air is a much healthier option when they're in bed. Well, let's think about that pad for a second, right? We've got urine. Now, urine is actually a little warmer than body temperature. Remember, our body temperature is about 98.6 degrees. Urine, because it's made up here in our furnace area, when it comes out, it's about 100 or 101 degrees. That's hot. That's hot, right? So that urine is going to spread out on that pad and encounter room air. What do we know about room air? It always wins. Yeah. So that 101 degree urine, as it spreads out on the pad, is going to cool down to room temperature. And that's going to make that pad feel cold, wet, a little slimy to the patient. If you were laying on that pad and it was cold and wet, what would you want done? Yeah, let's change it. So that's the first thing we're going to do is change that pad to get our patient on a dry pad and make them a little more comfortable. Now, we got a wet butt, a dirty butt on a clean pad. So at the end of the skill, after we've got them cleaned front and back, we're going to change that pad out one more time. So we end with a clean patient on a clean pad. Good? Makes sense? We're going to use our washing rules to do this. We already know this. Basins are no soap zones. We use a paper towel to turn the water on. We check it. They check it. We're going to use the leaves method for wet body openings. This is definitely a wet body opening. We need the leaves method for this. Don't add soap to your water. Whatever you wash, you rinse. Whatever you rinse, you dry. If the water gets cold or soapy, we're going to change it out. No lotion for this one. Oh, I'm going to skip these because we just did that. All right. So we're going to follow the care plan. Let's look at the care plan one more time. It says a female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. So how do we do this? We start with the opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? I need to do Peri-Care, or I need to clean you up, or I need to do personal care, or I need to clean you down below. Any of those will work. What we don't want to say is, I'm here to clean your hoo-ha. Okay, that's not professional. We want to be professional. Okay. We're going to close curtain, wash our hands, get a barrier, put it on the table first, go back and get the rest of our supplies. Washing rules. So let's get some water. We'll check it. They'll check it. And we're going to use a privacy blanket for this skill because we don't want to see those knobby knees. Gloves are definitely required. This is personal skin and body fluids. First thing your gloves should touch, though, is the patient. So that means you got to get all of your prep work done first. All of the prep work before you put those gloves on. So we're going to get that privacy blanket over the patient. We're going to get the gown rolled up and the towel over the legs before we put our gloves on. Or I'm sorry, let me back up. We're going to get everything ready to change the chucks under the patient, then we'll put our gloves on. So Becky says, Nurse Petty, it's been 4 weeks since I started working as a CNA, and I wanted to thank you for everything you do. I learned a lot from your videos, and it made my job less complicated. Oh, thank you so much for including us in your journey. Thank you. All right. So, yeah. One of the teachers that uses our materials, she tells the students to go have a patty party to practice the skills together. So that's kind of cute, patty party, instead of a pity party. All right, so we're going to change the chucks. We already know how to do this, guys. Clean rolls toward me, dirty rolls away. We know how to do this. This is just like the sheet, but smaller. We know how to do this. So we'll change that chucks out first. And once we get the chucks in place, then we're going to roll the gown up inside the blanket and put a towel over the legs because no knobby knees. All I want to expose is the area I'm working on. Okay. Once we have that area prepped, then we're going to clean. Now, when we clean, we wring out our washcloths because no drippy wet washcloths. We've learned that. We're going to wring that washcloth out and we're going to put soap on 5 leaves. So I'm going to hold it in the diamond shape. I'm going to put soap and fold that over. Put soap and fold that over. Put soap, fold that over. Put soap, fold that over, and put soap. And for the test, you're actually going to use spray soap. They have spray soap. Those of you that bought the practice kits, you have a little vial in there that has, looks like this. It has soap flakes in it. You just put a little water in it and it creates spray soap. So we're going to spray all 5 corners. And then we're going to clean downward. So I'm going to use my non-dominant hand. I'm going to have to switch my hands here, but my non-dominant hand, I'm going to retract her peri area a little bit with this hand to hold it open so I can get down the inside middle. So I would put the top of my hand at the top of her peri area and retract and hold her open a little bit. And then I'm going to take this washcloth and go down the inside middle. Never back up. This is one way only. So top to bottom, move away, fold that leaf. Never go back up. We don't do this. That's no-no. Okay, top to bottom, fold it over. Now I'm going to clean the outside of the peri area. So top to bottom, fold it over. The other outside, top to bottom, fold it over. And then this area here between the leg and the groin is that crease, that skin fold. So we're going to clean down the crease, top to bottom, fold it over, and clean that crease. Now this has been used, so we're going to set it on our barrier. And we're going to get a washcloth, and we're going to rinse. Same way, exactly the same way. So I get my rinsing washcloth, I wring it out really well. I hold it in my hand in the diamond shape. I hold her open, top to bottom. Fold that over, rinse the outside, fold that over, rinse the other outside, fold that over, skin fold that over, skin fold. Set that aside. Whatever we rinse, we dry. We have a towel right over her legs. So we're going to use that, pat dry, top to bottom. Don't go back up. We'll move the towel out of the way. And then we're going to cover the patient back up, scoot them toward us, and roll them up on their side. Because that urine that is on the pad is all over their backside skin. So we're going to scoot them toward us, roll them on their side so that they're in the middle of the bed. And then we're going to take washcloth number 3, wring it out really well. And I'm going to soap 4 corners this time. 5 for the front, 4 for the back. So I'm going to soap, fold, soap, fold, soap, fold, soap. Ready to go. And I'm going to wash from the anal opening up the center crease. I'll fold that over. I'm going to wash one cheek. Fold that over. I'm going to wash the other cheek. Fold that over, and then once more up that center crease because it's like a riverbed. All the urine's going to run right up that crease. And then I'll set this aside on my barrier. Whatever I wash, I rinse the exact same way. So I'm going to get my rinsing washcloth out of my basin, wring it out, hold it in a diamond shape, and I'm going to rinse up the center, fold it over, one cheek, fold it over, the other cheek. Fold it over and up the center again. We'll put that on the barrier. Whatever we rinse, we dry. So I'm going to use that same towel and pat all areas dry. But now I got a clean butt. That pad that was under them is not clean. Remember that wet butt was on that pad. So what do I want to do while they're up on their side? Change the chucks out again. So we're going to change that chuck. So now I've got a clean butt and I got a clean pad, and everything is happy. Good. Get them back on their back in the middle of the bed. I have gloves on. Where have those gloves been? All up in her business. Do I want to touch that sheet that's going to go right up next to her face with these gloves? But I need my gloves on. Where have these washcloths been? All up in her business. I need gloves on to take care of this stuff. So she's fine. She's covered. She's in the middle of the bed. She's safe. She's happy. She's clean. She's good. I'm going to take all this stuff over to dirty linen and get rid of it. I'm going to clean my basin and store it like we clean all basins. And then once I've got that done, I can take my gloves off. I'm not keeping up with my slides here. Put my supplies away. I can take my gloves off. Then I can remove my privacy blanket and do my closing. That's the skill. Like I said, you've already learned the steps of the skill. We just had to put them together. Good. This is not a hard skill. You're going to have a hard time because of where you're washing. The first couple times is going to be hard for you emotionally. Your patient, they're over it. You are not the first person to do Peri-Care on that patient. You will never. If you are the first person to do Peri-Care on that patient, you took a wrong turn somewhere. Because if you're the first person, that means there was a change in the patient. Changes should be reported to the, and the nurse should assess the patient. Right? So if you're all up in their business and it's the first time anybody's been in their business, you took a wrong turn. Because the first time should always be done by the nurse. Make sense? So your patient's over it. They do not have the same reaction you do. In fact, your patient probably knows Peri-Care better than you because you have to do this every 2 hours around the clock. So this patient's had Peri-Care done a bazillion times. Your first time, you're going to be all shaky. Don't let them see that. They're going to get scared. They know what you're doing, but talk them through it. Because if you are doing this quietly, there is a serious creep factor there. So if you don't have anything else to talk about your steps. Okay, I'm going to wring the washcloth out now. I'm going to put some soap on the leaves. I'm going to clean you, middle, side. That's fine. They know what's coming. There's no surprises there for them. That's fine. If you want to talk about last night's football game, do that too. I don't care, but don't do this quiet. That's just really creepy. Okay, good. We're not going to go there yet. All right, Jake, go ahead and show Peri-Care this time. Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to perform Peri-Care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies. I'll be right back. After washing my hands, I'll get my clean supplies. We're going to place the supplies on an overbed table, and we'll start with a barrier on the table, making sure that the absorbent side is facing up to catch any water spills. This gives us a clean place to put our clean supplies. For this skill, we're going to need 2 chucks. We'll need a towel, 4 washcloths, 1, 2, 3, 4, and a privacy blanket. We'll go to the patient area. And now I'm going to get a basin and soap. We'll place this on the overbed table. And I need a set of gloves. Now I'll go fill the basin. Miss Jones, I'm going to go get some water. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about a quarter of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. I'm going to set this on the barrier. And this is a privacy blanket. This is going to keep you warm and protect your privacy while we do this skill. I'm just going to stretch it out over your sheet. And then I'll pull the sheet down underneath the privacy blanket. And we're going to pull the sheet down to about your knees. Now, I'm going to prepare my chucks. I'll unfold them, hold them up lengthwise, and I'm going to roll it toward me. Clean rolls toward me. All the way to the end. I'll put this on the barrier and do the same with the second. I'm going to open it up, hold it up lengthwise with the absorbent side facing me, and roll it all the way to the end. Clean rolls toward me. We'll set that on the barrier as well. Now I can put my gloves on. I'm going to place the washcloth in the basin to warm. I'll take one of the chucks that's rolled. I'm going to lay it up next to the patient under the soiled chucks. And Miss Jones, if I can have you scoot toward me, please. And we're going to roll up on your right side so I can change the chucks under you. I'll help you roll. Okay, now that you're on your side, I'm going to take the soiled chucks and roll it in. Clean rolls toward me, dirty rolls away. I want to roll it so that the absorbent side is on the inside and the waterproof side is facing up. I'm only going to touch the waterproof side, and I'm going to tuck it underneath the patient's hip. I'll unroll the clean chucks and tuck it underneath the patient's bottom area, under the dirty. Okay, Miss Jones, come on back. Thank you. And if you can scoot to the middle of the bed. Thank you. I'm going to go around to the other side. Go ahead and scoot toward me. Thank you. And roll up on your left side. 1, 2, 3. And I will remove that chucks, the soiled one, and smooth out the clean. We'll fold this up and we're going to throw this directly into the trash can. Okay, Ms. Jones, can you scoot back to the center of the bed, please? Thank you. I'm going to expose you now. I'll make this as brief as possible. Please let me know if you're uncomfortable in any way. I'm going to roll the gown inside the privacy blanket, and this will expose the peri area. And then I'm going to use a towel over the upper thighs to keep all of that area dry. Now we're ready to clean. I'll take the first washcloth, wring it out, and soap 5 corners. We're going to use the leaves method, meaning the free ends are at the top of the diamond shape. I'll spray the first leaf, fold it over, spray the second leaf, fold it over, spray the third leaf, fold it over, spray the fourth leaf, fold it over, and the back. I'll set that aside. Now I'm going to clean the peri area. I'll hold the washcloth in my hand in a diamond shape, tucking in the 2 side corners, making sure I have control over the leaves and they're at the top so that we can minimize cross-contamination. Okay, Miss Jones, I'm going to start cleaning you now. I have to hold you open just a little bit, but let me know if it gets uncomfortable. So I'll take the heel of my hand at the top of the peri area, retract slightly, and spread her open a little bit. And I'm going to clean right down the inside middle, top to bottom, one direction only. Once I reach the bottom, we'll move away and fold that leaf over. I'm going to clean the outside peri area, top to bottom. Fold that leaf over. The other side, top to bottom, making sure I don't ever move back up. Fold that leaf over. The 4th leaf will go right down that skin fold, the crease between the thigh and the groin. We'll fold that over, and then we'll clean this skin fold, top to bottom, and we'll set that aside. Whatever we wash, we rinse. So I'll wring out my washcloth using that same leaves method, tucking in the 2 side corners. I'm going to retract the labia and clean top to bottom. Down the center, fold that leaf over. The 2nd leaf will clean the outside of the peri area, top to bottom. And then we're going to fold that leaf over. The 3rd leaf will clean the outside of the peri area on this side, top to bottom. I'll fold that leaf over. The 4th leaf will clean the crease, top to bottom. I'll fold that leaf over, and then we're going to clean this crease, top to bottom. And now we'll dry. Okay, Miss Jones, I'm just going to unroll your privacy blanket, putting the gown back over your legs, and I'm going to ask you to scoot toward me and roll you on your side so I can clean your backside. 1, 2, 3. And we're going to roll up, 1, 2, 3. We'll expose your backside, and the evaluator will hold the mannequin in place for this process. So now I can clean the backside. I'm going to wring the washcloth out. And this time, we're going to soak 4 leaves. So 1, we'll fold that over, 2, fold that over, 3, fold that over, 4. Set the soap aside. I'm going to start at the anal opening and move up the crease. Just like that. We'll fold that leaf over. I'm going to clean 1 buttocks. We're going to fold that leaf over, clean the other buttocks. We'll fold that leaf over, and then once more up the crease. We'll set this washcloth aside. Whatever we wash, we rinse. So I'll wring that washcloth out really well. I'm going to hold it in that leaves shape. I'm going to rinse right up the center crease. Fold that leaf over. We'll rinse 1 buttocks. Fold that leaf over. Rinse the other buttocks. Fold that leaf over, and then once more up the center crease. Now we'll dry those areas. So starting at the anal opening, we'll dry all of those areas. We'll set that aside. Now I'm going to take the new chucks, place it under the one that's on the bed, and we're going to roll this one toward the patient and tuck it under her hip, and unroll the new one and tuck it under the soil. Okay, Miss Jones, come on back onto your back, please. Thank you, and then scoot to the middle, please. And I'm going to go around and remove that soiled chucks. Go ahead and scoot toward me. And then we're going to roll up on your side, 1, 2, 3. So I'll remove that soiled chucks and smooth out the new one. Come on back onto your back and then scoot to the middle of the bed, please. Thank you. This will be thrown away. Okay, Miss Jones, you're covered. You're in the center of the bed. I'm going to go put your dirty linens away and clean the basin. I'll be right back. These items will go in dirty linen hamper. And I'll clean the basin the same way we clean all basins. We're going to dispose of the water into the sink, rinse the basin, dispose of the rinse water into the sink, set it down, disinfect it per facility policy, use a paper towel to pick it up, paper towel to dry the inside, throw that away, paper towel to dry the outside, throw that away, and one for the drawer. On the way, we'll pick up the soap, place it in the basin, use the paper towel to open the middle drawer, pick up the lotion and put it in the basin, and then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. We'll dispose of the barrier that's on the table, and then remove my gloves. Okay, Ms. Jones, I'm going to pull your privacy blanket up and put your sheet back in place. We'll make sure that the patient is covered and that we roll the privacy blanket up in a ball as we remove it from the patient. I want to adjust the sheet for neatness and appearance. And I'm going to go place this in dirty linen. Okay, Ms. Jones, are you comfortable? Is there anything else I can get for you while I'm here? Would you like a magazine? No? Okay, your environment is clean. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. Your bed is in the low position. I'm going to open your privacy curtain and go wash my hands. We'll return this table to storage before we go, leaving our area clean. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. All right, so we have to go back and learn one more skill that we didn't get to from class 2. So if you turn in your books, I don't have any slides for this. If you turn in your books to page 76, we're going to learn range of motion shoulder. Now, there's nothing to teach you. You already know everything you need to know. What we need to do is read the care plan for this skill to find out what we're going to need to do. So if you look at the top of page 77, you'll see, provide the following range of motion exercise to the resident's left shoulder. So which body part? Can I do the right too? No, left shoulder only. Flexion, extension, and abduction, adduction. So if you remember, flexion, extension looked like this, straight up, straight down. Abduction, adduction brought the arm out to the side and back in. It tells me to do 3 repetitions of each exercise, and the patient isn't able to help with the exercises. So we're going to do our opening, then we'll bring the arm up and down 3 times, bringing it all the way back to start. We're going to bring it out to the side 3 times, bringing it all the way back to start. Monitor for any pain or discomfort, and then do our closing. That's the skill. That's it. Man, those look real easy now, don't they? Especially after a 17-minute skill. So let me show you the video for this. The rest of the class will be practice. Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some range of motion exercises on your left shoulder. Is that okay?
Yes.
Let me close your privacy curtain and wash my hands. I'll be right back. Okay, Mr. Jones, the first exercise I'm going to do is bring your arm above your head and back down to the bed like you're asking a question. I'll do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay?
Okay.
So we're going to bring your arm all the way up, supporting at both joints. Slowly and smoothly, all the way back to start. Here's one. We're going to do that 2 more times. Up, still okay?
Yes.
Back to the bed, and 1 more. Up, and back to the bed. Okay. The next exercise we're going to do is bring your arm out and back in like you're making a snow angel. Okay?
Okay.
So I'm going to support at 2 joints. We're going to go all the way up and all the way back to start. Feel okay?
Yes.
All the way up and all the way back to start. Still okay?
Yes.
1 more. All the way up and all the way back to start. Good?
Yes, ma'am.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. Bed is in the low position. Let me give you your call light. Here's your call light. If you need anything at all, just press that red button. We'll be happy to help.
Thank you.
I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right. And that concludes our lessons for today. Over the weekend, you are going to have 2 chapters of homework, chapters 8 and 9. 8 is on nutrition. We talked a little bit about that earlier today. And 9 is going to be on rehabilitation. So it's going to talk about adaptive devices and prosthetics and physicians and the role of different team members when it comes to rehabilitation. It's not a very long chapter. It's not a very hard chapter. So their homework is getting a little bit easier. And then please remember, you will have to bring those books back to me on Wednesday of next week on graduation day. So if you're behind on your reading, this is the weekend to get caught up because you have to bring that book back to me on Wednesday. Jake, do you want to pass out the review sheets? And then I'll get this over to you in just a second. Or you can get into my phone. All right. All right. Any questions on what we've gone over today? Any questions? Yes. Male. So male Peri-Care is going to be at the end of that lesson in your book. It actually has a whole section on male Peri-Care. It's very similar to female Peri-Care in that we always wipe away from the urethra. So, but I've got a whole section in the book that's going to cover it. It is not going to be demonstrated on the state exam because the incidence of infection is much higher in females than males. So it's much more critical that we demonstrate it on females for the exam. Peri-Care, male Peri-Care.
But it's possible for it to happen.
Female Peri-Care will be, maybe on the exam. Male Peri-Care will not be. Any other questions? We're now down to the last 3 skills. We're going to learn bedpan, catheter care, which is a variation of Peri-Care that we just learned. It's Peri-Care with an extra step. And emptying the drainage bag, which is a 3-minute skill. That's what we will learn on Monday, and then you will have the rest of Monday to practice. Okay? Class going okay for everybody? All right, so there's one more thing I want to talk to you about before I let you go today, and that's the practice test. In your white skills book on page 192, there is a practice test that is 60 questions, very similar to what you're going to find on the state exam. and I'd like you to take it sometime before graduation. If you miss 5 or fewer on the practice test, you are ready for the written test. If you miss more than 5, then you need to download the ebook off of the website and read it, go through it. It's a good thing to download anyway so that you have it. But if you miss more than 5, you definitely need the ebook.
The yellow one or the
No,
or the white one?
The ebook is something different. It's not something that I have in class. I only have one physical copy. I only had one printed, and it looks like this. But it's going to explain to you the type of categories that are on the state exam. It's workbook style, but it's done in a different format than anything else I have. But if you just go to 4YourCNA.com/ebook, you can download it there. Okay. But it will help you on the written test. Don't take the written test until you've finished reading 8 and 9, though. Read 8 and 9 so you have that knowledge before you take the practice test. Okay, good. And then I have one more practice test for you on the main website. We'll talk about that on Monday for you to practice for the exam. Good. Anything else? Any other questions? Is class going okay for everybody? Everybody doing okay? Am I going too fast? All right. Okay. We're going to go ahead and sign off of online then. Thank you so much for joining. I'll see you tomorrow for the game show at 11 a.m. Don't forget. Okay. We'll wait for questions from chat. Tomorrow, the game show, 11 a.m. and then graduation here on Wednesday. And if you want to learn how to answer that question, tell me a little bit about yourself that shows up in every interview, no matter what you're trying to get. Tune in on Wednesday. I'll give you a really cool way of learning how to answer that question. All right. Any questions in chat? Okay. Well, let's go ahead and put the end screen up, Jake, and we will sign off for today. The rest of the class is practice. You are not required. There's only 15 minutes left. You're not required to stay for practice. You can certainly leave if you choose to do so. But if you want to practice, the bed is here, the mannequin is here, and all of the supplies.